Hello, YouTube. I am trying to get Facebook started here. Lots of technical difficulties today. Give me a quick moment, okay? Hold on one sec. Okay, I got the stream running. Okay, where is that? Hold on one sec. You know, I think my streaming computer is dying. It is not cooperating. Hold on one second. Hi, you guys. My streaming computer is... Okay. Let's see here. Let us see. No, I don't want to well, yeah, you can restore pages. There we go. Hi, Rhonda. Hi, Hitatsu. It's been a busy morning with the folks. It's just one of those days. All right. So hold on a sec here. I'm almost... Let's see more. All right, Facebook live video. We're almost there. I am normally not this late, but the parents were difficult this morning. Cystitis support. Hey, cool. And really nice to meet you. I work with a ton of men. That's actually kind of my specialty because my first support group was filled with men. And I think I was the only one in the country who, I've worked here. One sec. Okay, so streaming computer, settings, stream. I gotta put the stream key in. Bam, done. Make sure we got audio. Okay, we've got audio. Start streaming. Yes, I want to start the stream. I'm all discombobulated. Okay. All right, we're going live on Facebook. I'll be right back. Okie dokie, artichokes. Okie dokie, artichokes, here I am. Hello, everybody. Jill Osborne from the Interstitial Cystitis Network. It is Sunday, February 19th. Holy moly, the month is flying by. We got started a little bit late because my parents needed a lot of extra help this morning. And yeah, it just is what it is. It just is what it is. You got to put their clothes on and help them take showers, get in and out of the shower, do personal care, make all their breakfast and stuff. So we just wasn't easy this morning. So anyway, my purpose in doing these meetings is to make you so strong, so knowledgeable, so informed that no one can mess with you again. I don't want anybody telling you that it's all in your head. I don't want anybody telling you that there's no hope. I don't want anybody telling you that there's no cure. Baloney. In the old days, yes, we thought IC was an incurable bladder disease, but today we don't. Today we think of IC as a pelvic pain syndrome. That's not just me saying that on the internet. That is actually the American Urology Association and their latest guidelines. And why do they say that? Because there's no active disease process found in the bladders of the vast majority of patients. There's no disease other than perhaps patients with Hunner's lesions or patients who have chronic UTI. Okay, but for the vast majority of us, it's your nerves and muscles that are driving their symptoms. So we got started. Normally when I do these meetings, I do like a little 30-minute intro, a little educational piece, and then I take your questions. I don't really have a 30-minute intro for today. I do have something. We're just putting together our magazine, the IC Optimist. It's at the typesetter right now. I just got the cover. And I have a fabulous guest editorial by Dr. Robert Eckenberg. And Robert Eckenberg is the premier pelvic pain specialist in the United States, if not in the world. This is the guy, the gynecologist who treats men, just so you know, he treats men, who saw very, very early on in his career that we can't typecast these symptoms, or we can't automatically assume that everybody with pain on bladder fill has a bladder issue, or everybody with pelvic pain has a gynecological issue or a prostate issue. That we have to be respectful and understand that there's a lot of things that are influencing the pelvis. There are a lot of things that are influencing the pelvic cavity. You've got muscles, you got nerves, you got giant blood vessels, you got giant nerves too, just so you know. The nerves are really massive in the pelvis, the big web of nerves. We've got your GI tract, we got your urinary tract, we got your reproductive tract, and nothing operates in isolation. And that's really where Western medicine fails the typical IC patient, because in Western medicine, you go to a specialist. Well, the specialist, they're specialized in the urinary tract. But what happens if you have your hydrodistension or your cystoscopy and your bladder is normal? So you're getting up, you're going to bathroom every 30 minutes, every 45 minutes, but your bladder's normal. Okay. Are you going to do bladder treatments for the rest of your life? Hell no. And that's what our AUA guidelines say. If you're not responding to therapy, if you're getting worse rather than better, we need to take a step back and revisit the diagnosis. And so rather than being disappointed when a doctor, here you're at the doctor, you're begging for answers. And the doctor looks in your bladder and goes, I don't see anything. And you're like, what? I'm up all night. What? It's got to be messed up. There has to be something wrong with my bladder. And they're like, no, it looks fine. I don't see anything. Now, for most of us, when that happens, and that's happened to all of us, we're just like, oh, really? Then what else is causing this, right? Or you get the rolling of the eyes, you get from a family member who might be with you. See, I told you nothing's wrong with you. Oh, it's all in your head, all that sort of stuff, right? But I want you to look at a positive hydrodistension and cystoscopy in a different way. That's great news. You're like, bam, excellent. I'm glad to hear you don't see anything wrong with my bladder or wall. Now what we have to do is figure out what's driving these symptoms. So if it's not my bladder, what else can it be? Could it be a fibroid tumor pushing on my bladder? Could it be ischemia, muscles so tight they're restricting blood flow to the bladder and causing the bladder to react? Could it be a low back injury? Could it be a Tarlov cyst? I mean, could it be a problem again with the circulatory system, ischemia or pelvic congestion syndrome, which is basically varicose veins? Okay, Facebook. Yikes. Just got a little delay of error. Okay, we'll cross our fingers here. So you as a patient, let's take the successes for what they are. You got a healthy bladder, bam, that's great. I have a healthy bladder. And ultimately, your journey into pelvic pain and your journey into understanding IC is basically a checklist. And when you go to the doctor, this is about having a doctor study your body. We need to try to understand the totality of your pelvis. We need to try to understand the totality and in all honesty, the history of your symptoms. Because so many of you have a history of trauma that you don't tell your doctor about. It might have been a long time ago, or you just didn't, you're thinking bladder, UTI. Why do I need to tell them that I fell? Why do I need to tell them that I had surgery? I was working with a patient this week who, very, very interesting. literally when she was born, she almost died. And she almost died because her ureters were not properly connected to her bladder. And so body waste from her kidneys was draining into her belly. Okay. And that's a birth defect. And so imagine this infant, they have to go in and they have to do, I think she had 2 or 3 surgeries before the age of 5 to try to reattach the ureters and get her urinary tract functioning in a healthy way. But I want you to think about the scars that caused, these multiple surgeries that caused. And what was interesting about her case is that so here she's got all the urinary symptoms, her bladder is healthy, but her muscles are like rocks, hard, stiff. And again, I asked her, is sex painful? Yes, it's been painful. Or I have to take a Valium to have sex. I've got to relax the muscles. And it's like, okay, so let's think about this for a moment. And you guys, just so you know, allergies are really bad. So if I rub my nose, just don't take that personally. So, you go back in history and it's like, okay, she can only have sex if she takes Valium. When I asked her, I said, well, do you know what Valium does? She goes, no. I go, it's a muscle relaxant. Oh, it's a skeletal muscle relaxant. Oh. So what is that telling us? That's telling us that it's and you feel better when you take Valium, right? Yes. So that's telling us then that it's your muscles that are driving a good portion of these symptoms. And she just really hadn't even thought of that. She hadn't heard of the concept of ischemia and all that sort of stuff. And so, in the end, you're a checklist. You're a checklist. We gotta rule out the bowel. We gotta rule out the reproductive tract. We have to rule out muscles. We got to just rule out stuff, especially if you're not responding to therapy. And the great news here is now that we're doing that, now that we're doing phenotyping/subtyping, where we're looking for underlying cause, more people are getting better quickly. And as Chris Payne said in his proposal 7 years ago for five core subtypes of IC, it is cruel to tell patients that they have an incurable disease when in fact they have a curable injury. So you are an anatomical mystery to be solved. And it's hard. It's so hard for some of you to go, but it's my bladder, but it's my bladder. But it's like, honey, your bladder is normal, right? Yeah. Okay, then it's not your bladder. Let's celebrate that for the success that it is. Rhonda says on here on YouTube, because we're simulcasting on Facebook and YouTube, pretty much the same thing happened to me at birth. My tubes were not long enough to reach my bladder. I was also born with duplex kidney system. Yeah, exactly. So I'm going to come back here to YouTube for a moment. So Hitatsu is on YouTube, and he's a gentleman who is struggling with cystitis, 32 years old, and his main problem is urinary incontinence and sudden urgency, which started all of a sudden. You had an ultrasound, and my bladder thickness is 8 millimeters. Interesting. However, I don't have any pain. I'm not from the USA. There's no pelvic floor therapist in my city. Okay, so Hitatsu, if you're still here, how old were you when your symptoms started? How old were you? And is there any event that you associate with the onset of your symptoms? Were you a bike rider? Were you a motorcycle rider? Do you have any crashes? Were you playing football? Were you playing soccer? Was there any sort of trauma? That's question number 1 for you. And question number 2 for you is, have you ever used ketamine? Hi, Caroline. Caroline says, hope you're okay. Yeah, we're doing okay. We're just dealing with elder issues today. Kayleen says, I am with Valium. It's a beautiful drug when used responsibly. Girl, I hear you. I got no problem with that at all. Bobby says, what would a small cystosome seen on cystoscopy? I don't quite understand that. Did they see a small cyst in your bladder on cystoscopy, or are they saying your bladder dome is small? Hi, Deborah. Hi, Gay. Hi, Paula. Caroline says, you just had Botox and a bladder stretch under general, and they found lots of cysts that I had burned off. Please help as I'm worried. Caroline, did they take pictures of your cysts? Can you describe them? I mean, were they like little white bubbles? What were they? Hi, Anne. You were 31. Okay, so Hitatsu, was there any event that you associate with with your symptoms, the onset of your symptoms? Hi, Priyanchi's here. Hello, hello. You're not a bike rider. Okay. Do you work out? Do you go to a gym? Do you work out? And you guys, I am not quite 2 weeks post bone graft. So the mouth is still a little sore. You never use ketamine. Excellent, you guys. The reason why we ask about ketamine is a very popular drug used at raves, very popular around the world. It's actually replacing heroin as a drug of choice. And you get what we call a dissociative high. You feel like you're floating. The problem with ketamine is that it damages the bladder. It damages lots of structures in the body, especially the bladder. It's kind of like an industrial solvent in the bladder. So we always have to ask about that. So again, Hitatsu, can you remember any physical traumas? Because I'm going to tell you right now, 90 to 95% of the guys that we work with have a history of trauma. Have you ever, like one gentleman I worked with who was sliding on his wood floor he was doing the Tom Cruise impersonation from that movie where he was sliding in his socks on a wooden floor and his feet fell out underneath him at the top of some stairs and he landed on his tailbone and he went down the stairs on his tailbone. And literally the next day, all of his symptoms started. All of them. It's a yes, you had a severe contamination. Let's see. Okay. So you had COVID then. So he says, yes, you had severe contamination OCD, which was triggered by COVID. Not girl, dude. Who doesn't feel that way? Who doesn't feel that way? I feel that way. And you had anxiety? Sure. They're completely understandable. But you had COVID. And COVID is known for causing something called COVID cystitis, which is a severe inflammatory reaction of the bladder wall. So you had COVID last year? How long ago? Was it 6 months ago, a year ago, 18 months ago? Your psychiatrist told you your urgency was due to anxiety? Yeah, right. I'm thinking about how would that happen? I mean, listen, if you're under extremely high periods of stress, your body prepares to fight or flee, and that will make you pee, and that will make you have bowel movements. If you tell me I've got to get on a plane tomorrow, I promise you I'll be up all night peeing and pooping. That's a stress response. That's a stress response. It says his OCD was triggered by the pandemic. You have millions more, hun. I don't want you to feel any shame about that. Listen, this is surreal times. There isn't anybody out there living right now who doesn't have, to some degree, some stress, anxiety, and in fact, OCD about COVID. It's one of my insurance agents just died. Suddenly, she was young. from COVID. We've had several new deaths of COVID here in my county. Well, okay. So what are you doing then about working on your stress and anxiety? I mean, the stress response is real. Your body is always hardwired to save your life. That's why when you open up your front door and see a saber-tooth tiger, its stress response will immediately take over. Fight or flight will immediately take over because it has one job, to save your life. And you can't think yourself out of that. This is the brainstem. This is the most primitive part of our brain. And so what we have to do is we have to prove that we're safe. And the way we do that is with good sensory information. So what do you see? What do you hear? What do you smell? What do you taste? What do you touch? Your five senses. So I do a technique called I Spy regularly, which is designed to break you out, out of fight or flight, to calm that stress response down. And incorporating something like that in your daily life is just so incredibly important. Good. He says it's under control. Awesome. So how are your symptoms now? How are your symptoms now? Are you better than you were 6 months ago? Okay, Bobby here on here. Kayleen says, can we Zoom later? I want you to tell me what I can talk to my doctor about. Let's see how the day goes. Kayleen, maybe. I got to see how the folks are. First, because it's a little hairy day. My mom's had this bad nosebleed, and okay, cool. I'm really proud of you. I'm really proud of you that you did what you needed to try to get everything calm and collected. Good job, Hit. Really, really, really good job. You know, God didn't give us the skills to deal with this crazy life when we're born. We have to learn them. And that's really hard when you're in your teens and your 20s and your 30s, because we like to fake it. It's like, oh, I'm fine. You know you're not fine, but as you're going to tell everybody, I'm fine. I don't need help. I'm fine. And that's the gift of getting older is knowing that, you know what, we just didn't have the skills. We haven't learned the skills. We have to go learn those skills. Right? And that's why going and talking with a therapist and going and get that help is really a great thing, because it's all about skill building. Oh, I'm so glad that you're better. Awesome. Are you sleeping through the night? Oh, so Bobby, getting back to Bobby. Hi, Nancy. Bobby says that didn't make sense. There was a cyst that was not inside of her bladder, but was pushing in on the bladder during the cystoscopy. It moved when she pushed water towards it. She said it could be intestine pushing, or more likely, maybe even a fibroid tumor, Bobby. I mean, fibroid tumors are very interesting, because you think about your uterine wall for a moment. You can have a fibroid tumor completely inside your uterine wall. You can have a fibroid tumor that's and when I mean inside the wall, I mean inside the meat of the uterus. So it can be contained entirely within the uterine wall, or it might poke half from the uterine wall, half into the uterus, or it might poke the other way, half in the uterine wall, half outside of the uterine wall, pushing right into the bladder. Can that happen after a hysterectomy? No, if you've had a hysterectomy, you don't have a uterus anymore. So there's another kind of complication that happens after hysterectomy. It's called the vaginal vault collapse. You know, because the challenge with having hysterectomy is they're taking out structures, and you know, the bladder basically is literally proximal to the uterus and the vagina. It's all connected. So when you remove structures, now we've got things that might not be anchored well. And sometimes there can be a prolapse, a variety of different types of prolapses that can happen after a hysterectomy. One is called the vaginal vault prolapse. And so Bobby, if I were you, I would be headed right to your OBGYN, because how long ago did you have your hysterectomy? Hit says, have I seen many cases of bladder thickness of 8 millimeters? Will my bladder get back to normal? Yeah, I mean, it's fairly common. It basically means that, okay, I wish I could structurally verify this. When we think about the bladder wall, you've got an inner mucosal layer, then you've got a layer of cells, and then you have the smooth muscle of the bladder. And the smooth muscle of the bladder is the muscle that expands and contracts as your bladder gets full or not. So muscle fibers are arranged like this. They're long fibers that are right next to each other. And when the muscles get tight, they do this, right? That's exactly how the muscle fibers slide. So this is a tight muscle. This is a lean and healthy muscle, right? So lean and healthy muscle, tight muscle, thicker, right? That's thicker, right? So I would have to wonder if something like the bladder holding protocol would be useful. It says, my doctor prescribed me oxybutynin. Oxybutynin is a smooth muscle relaxant. So that makes total sense based upon what I just said. If your muscles are tight and spasming, oxybutynin will help to relax them. So that's perfectly reasonable. And they're giving you cranberry and D-mannose tablets. That doesn't make as much sense unless you have a history of UTI. If you have a history of E. coli-based UTI, then doing D-mannose makes sense. Cranberry, not so much, because cranberry can be acidic. You have to do potentially a proanthocyanidin D-mannose supplement like a Prevent in our store or Allura. Okay. Yeah. So ask your doctor about bladder holding protocol, because when you do the bladder holding protocol, you're basically teaching your muscles to expand again. And it's a very slow and gradual process. If you're normally peeing every 30 minutes, you would then go to 35 minutes for a couple of days. Then you go to 40 minutes for a couple of days, 45 minutes for a couple of days. You know, I did surgery, right? When I got my degree in pharmacology, I had a year of surgery on animals, anesthesia and surgery. And I love animals, which is why I don't work in that field anymore. I can't tolerate what they do. It's just bad. And the work I did was very ethical, and I never, ever, ever lost an animal, ever, in my entire academic career. Never. Okay. Which means I'm not hardwired to be a good drug scientist because they experiment on animals. Okay. Anyway, in doing the surgery, what was so interesting is how incredibly stretchy and pliant muscles are. So I could make an incision that was just an inch, like an inch long. And using forceps, I could just gently stretch the muscle until that hole was two inches long. And it's amazing how responsive and reactive muscles are. And so bladder holding protocol is doing exactly the same thing. It's just kind of slowly reminding that bladder and the muscle fibers in that bladder that that their purpose is to expand and contract. Yours just got kind of locked down tight. So I would give that a shot and see how you did with that. Hi, Deborah. Deborah had to leave for a minute. That's okay. That's okay. Prasid said, do I have a pet? Not right now. I grew up with lots and lots and lots of animals. If you go back to some of my early videos, you can see my beloved cat, Sammy, walking across you can see her tail walking across the video. But I lost her in 2017. And it just was agony. She was that one special pet. And I've got my hands full caring for my elderly parents. I cannot take on another responsibility. I just can't. I've had a couple of chances, but between the fires and elder care, I'm one of those people where if my pet is sick, I'm up all night with them. I can't sleep. I mean, I just love them to death. And I don't care what they are. I've had cats, I've had dogs, I've had horses. I've actually had rats years and years ago. Had a rat in college. That was pretty cool. Jody said, my hysterectomy was 20 years ago. I had the pain I'm having now back then, and it started at 5 years ago, and it has gotten worse over time. All right. So Jody, you are 20 years post-hysterectomy. You are 20 years older. That means you are 20 years less on estrogen, which would then cause muscles, your pelvic floor muscles, to become slowly weaker and weaker and weaker. And so I would really have to wonder if you're having estrogen-driven muscle weakness, a pelvic floor dysfunction, and or estrogen-driven bladder wall dryness and vulnerability. And Bobby said, can that happen after hysterectomy? Absolutely. Absolutely. Bobby had her hysterectomy a year ago. And so that's exactly in the time frame where we would expect to see something like a vaginal vault collapse. You need to go back to your gynecologist. You need to tell them very, very specifically that when they did your cystoscopy, they saw something pushing into your bladder. So could it be intestine? Maybe, but it's far more likely that it's something like a vaginal wall collapse. But I obviously am not a doctor and I can't give you medical advice. You need to go back to your OBGYN right away. We need to get this checked out. Vaginal vault collapses are repairable. Kayleen, okay, not a problem. Let's just give it a little time. Hello, Nancy. I too had to have a bladder sling after your hysterectomy. Exactly. Elena said, my physical therapist told me that physical therapy will not help my pudendal burning and bladder because my pelvic floor muscles are relaxed. Nerve blocks won't help me either. This month I used tampons and my frequency in bladder pain returned. Food doesn't seem to have an issue. I have pudendal burning every second for 1 year. You're taking antidepressants and benzos. Don't know what to do. Only benzos reduce my pudendal neuralgia. Alina, do you know how it happened? How do you think you ended up with a pudendal neuralgia? Did you have a baby? Was there some sort of injury? Because normally there's some sort of injury or trauma that would cause that. So take us back in time and tell us about that event. Wynn said, a friend's 20-year-old daughter was just diagnosed by symptoms in the potassium sensitivity test. I didn't think doctors were using that. When you're right, in the new AUA guidelines, the potassium sensitivity test is no longer recommended. All it does is it tests the superficial integrity of the bladder wall, but it can cause a false positive because you take a menopausal woman who's not having bladder symptoms and you do a potassium sensitivity test, she's going to react to it too. Even somebody on birth control could react to it. So thrown out. And you guys, hold on. I need to go get my SI, but my SI joint's hurting. Give me a moment. So what is, let me just get my model here and explain this. Okay, so why are my pelvic floor muscles tight on my left side? And they've been tight for years. Deb says, are you still doing Instagram? My sister was watching you. Yeah, kind of off and on. We just didn't get a lot of participants and it was distracting. I think if I'm going to do Instagram, I'm going to do it by itself. It's just been a very busy couple of months. Okay, so why are my pelvic floor muscles always tight on my left side? Well, I want you to look at the back here for a moment. So we've got your vertebrae, we've got your sacrum, we've got your hip bones. And the joint right here, which attaches the hip bone to the sacrum, is called your SI joint, your sacral iliac joint, right? This is meant to be a rigid joint. It's not meant to move. But for some of us, it does. And in fact, I was a professional tennis player as a teenager into my early 20s. That's how I paid for all my college. I was teaching tennis for a variety. I mean, I played tennis, professional tennis, won a few tournaments, wasn't that good. Then I taught a lot of tennis at clubs and spas, and UC Santa Barbara too. I taught there. Okay, so anyway, think about tennis for a moment. This is important. You need to understand this. Okay, so for tennis, you step in, you have your, so with tennis, you step in and you swing and you go like this, right? So you're putting all of your weight on your sacrum and then you're rotating it. And what does it do? It opens it up. It opens it up. So my SI joint on my left side is truly screwed up. So, and it's a classic tennis injury. I worked with the physical therapist for the U.S. Olympic tennis team. He was also a physical therapist for Yvonne Lendl. And he said, yeah, you've got Yvonne's injury. Great. Yvonne made a lot more money than I did. So anyway, what we do is we use a belt to hold the joint together. And so what I do is, I'll put it on the outside here, right around the joint. Whoops, hold on. Just right there. See? It's right over the joint. Now I can go months and not need it. I can go absolute months and I'm fine. And all I have to do is bend the wrong way and bam, there it comes back and I got to use my joint. I got to use the belt. Hello, Missy. Missy said, good afternoon, Jill. I just want to thank you for the phone call earlier this week. You're such a wonderful and caring person. This is your new friend from Kentucky. Oh, honey, it was nice to talk to you too. I really love talking to patients. It's very cool. It's very cool being the first person with IC you've ever potentially talked to, but just giving you that helping hand, you know. Sometimes we all just need a little bit of help. No shame, no blame. See, so now that I have my SI belt on, it's not hurting. because the joint is being held together. And I want to start playing tennis again so badly, and I shouldn't, because it will only make it worse. And we don't want to have surgery. I'm condemned to bouncing it. I'm condemned to bouncing a tennis ball on my racket now. That's about all I can do. SI belts are available on Amazon.com. That's where I got this. They can be white. They can be lots of different colors. It has saved me. Okay, so Elena, getting back to Elena here for a moment. Elena, her pudendal neuralgia started after a bike ride. Okay. Okay, so, and the book you need to get, Elena, is Stay. Okay, this is the book you need to get, Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss. He talks very, very specifically about what happens riding bicycle seats. And let me just go to that section, and I can actually potentially even read it for you. I just have to find it. Okay. So I want you to look at this bicycle seat. Okay, so you can see that when you sit on the bicycle seat, see the nerves right there? The nerves right there? The bicycle seat pushes directly into nerves. That's why the human body was never designed to sit on there. So here, let me just, let me read this small section to you, okay? I think you might find this really helpful. Okay, here, hold on a sec. So, and understand too that many patients experience clitoral pain and penile pain, and so he's kind of talking about that in context. So this is Dr. Jerome Weiss. I must confess that I too once believed that the muscles were the primary cause of most pelvic pain syndromes, including clitoral and penile pain. In fact, the original working title of this book was The M Factor, M being myofascial. In recent years, however, my awareness of the pudendal nerve pathology has grown exponentially. Knowing what I know now, I'm finding that the pudendal nerve could be the immediate culprit in most cases of clitoral penile pain and also numbness based on solid clinical results. So what do cyclists know today that many doctors didn't or still don't? In 1987, French neurologist Gerard Amarenko published an article about pudendal nerve entrapment, which he dubbed cyclist syndrome. Amarenko reported that pressure exerted by a bicycle seat upon the pudendal nerve could injure and ultimately entrap it, causing clitoral and penile pain, numbness, orgasmic and erectile pain and dysfunction, pain with sitting, and other symptoms. Though Amarenko's insights began to filter into American medical journals over 20 years ago, many practicing physicians remain unaware or are only peripherally aware of pudendal nerve entrapment and the problem it causes. Yet bicycle magazines are presenting cutting-edge information about genital and sit bone trauma to the mainstream public that is enabling readers to diagnose their own problems. In particular, several of these publications have featured articles about bike seat neuropathy, the sports med lingo for pain or numbness in the sit bone, scrotum, penis, or clitoris. These symptoms can all be caused by pressure applied by the seat, which can damage the pudendal nerve and cut off blood supply to the genitals. Here is our, so he's talking about this picture. Here, our artist has depicted a professional bike seat with a thin nose, which is frankly an ergonomic nightmare. You can see how the nose exerts direct pressure on the nerves in the alcox and clitoral penile canals. So the pressure increases exponentially when you pedal faster and sit forward on the nose, right? So here's the picture again. Here's the nerves. So imagine what happens when you bend over. Now we're pushing those nerves more firmly into the bicycle seat. Hold on, where was I? Pain or numbness in the sit bone, scrotum, penis, and clitoris can be caused by pressure applied by the narrow bicycle seat, which can damage the pudendal nerve and cut off blood. A narrow seat provides insufficient cushion space to support the sit bones properly. Therefore, you must balance your weight on that part of the pubic bone to which the genitals are attached and under which the clitoral and penile branch of the pudendal nerve travels. This nerve branch runs inside the sit bone rather than the clitoral penile canal beneath the pubic arch. Okay, well, you don't need to know that. It has been suggested that serious cyclists use a two-cheek noseless seat to avoid neural compression. While this approach may accomplish its objective, several patients have told me that they nearly flew off that type of seat when rounding a bend in the road. I would therefore advise avid cyclists who are suffering from chronic pudendal neuropathy to either give up the sport or be prepared to endure the consequences. However, some cyclists only appear transitory pain and or numbness that it disappears when they're not riding. They may be able to solve the problem by simply giving their seats a periodic rest. Additionally, some physical therapists are now analyzing the ergonomics of bike seats for their patients. This would certainly be worth a try, particularly for non-competitive recreational bikers. What else can cause this type of pain? Horseback riding. Oh my God, we're having a run on horseback riders here at the IC Network, especially if you're posting, if you're writing English and posting. Posting is when you trot, and to avoid doing this, you actually move your hips up and down in time with the trot, so that you don't you're in harmony with the horse. But with posting, ultimately you're going up and down directly onto your pelvic floor. What else? Habitually sitting on hard, uneven, or uncomfortable surfaces, like uncomfortable office chairs, give bike seats and saddles a run for the money. People whose work requires sitting for long periods of time in ergonomically deficient chairs are prime candidates for both genital and tailbone symptoms. Gynecologic, urologic, proctologic, or hip surgeries can directly traumatize the pudendal nerve. For instance, during many hip operations, a perineal post is pushed deeply into the area between the sit bones to open the hip joint by applying traction to the leg. The pressure created by this post is not unlike that of riding for hours on a hard bike. Childbirth, constant constipation, or a sagging pelvic floor. And pain referred to the pudendal nerve can irritate and inflame it, such as pain from muscles and nerves and backs and stuff. Stressed or injured pelvic floor muscles, such as the piriformis, can compress the main nerve. Tight dysfunctional muscles, particularly the urinary sphincter, can contribute to clitoral penile pain. Then he talks about something called a double crush syndrome. So let me read a success story, okay? Because I think this will help. This is Michelle's story. Sorry, you guys, allergies are really bad, and my whole body is just kind of like annoyed right now. So, okay. Michelle's story. At the time of her first appointment, Michelle was in her early 40s and had been suffering for a year with a deep, aching clitoral pain, accompanied by a feeling of swelling that often hit 8 on a scale of 10 and was literally robbing her of her life. It was present with sitting, standing, walking, decreased only slightly when lying down, and gave her a nauseous, faint feeling when it escalated. Her pain was so intense and unremitting that it prevented her from working, causing severe sleep deprivation and left her feeling perpetually depressed. At the onset, Michelle's pain felt like a severe external clitoral irritation. She immediately saw a female gynecologist who did not examine Michelle because of her discomfort. Instead, she performed a laparoscopic myomectomy, a procedure for the removal of uterine fibroids, but found none. However, she did find small cysts in an ovary and fallopian tube, 2 tiny cysts on the clitoris, and some endometrial tissue. Some endometrial tissue outside of the uterus, all of which she removed. Yet the clitoral pain was undiminished. Therefore, she performed another surgery for the removal of 2 more very small ovarian cysts, again without relieving the pain. At this point, the gynecologist stated that the pain appeared to be in Michelle's head, but nonetheless, she performed a third surgery for the removal of additional cysts, the locations of which I did not notate in the chart. When the symptoms remained after this procedure, she told Michelle there was nothing she could do. So that this woman had her ovaries, fallopian tube, and other tissues either removed or whatever. Okay. Michelle then consulted a gynecologist urologist who performed a laser procedure at the tip of the clitoris without effect. After a subsequent MRI of the pelvis showed no abnormalities, he referred her to a pain management specialist who provided or prescribed a lot of meds that failed to relieve the pain and referred her to another urologist. Finally, Michelle came to me. And again, this is Dr. Jerome Weiss. When I attempted to examine Michelle, she was so tense and anxious, I was unable to complete a thorough internal exam. In fact, I was barely able to palpate the clitoral branch of the pudendal nerve, which was extremely tender, just above the Alcock's canal and under the pubic bone. I wondered what had caused the nerve to become so exquisitely sensitive. There were periods were extremely painful. Michelle had no pregnancies that might have affected the nerve, nor had she experienced pain with sex. She recounted no history of accidents, falls, or strenuous athletic activities that might have injured the nerve. There were no urinary, GI, or obvious biomechanical problems. That day, I recommended she return for a diagnostic pudendal nerve block with possible trigger point injections in her multiple scars and a physical therapy evaluation. The bilateral blocks of both clitoral branches produced excellent results. Her pain completely subsided for the first time in a year, and she remained 90% better for 8 days before the symptoms began. So clearly, these nerve branches are the primary pain source, and I suspect that a series of blocks will be required to achieve long-term relief. It will also be necessary to identify and address the root cause of the nerve pain, and it appears that this will be a challenging assignment. Now, unfortunately, Michelle's anxiety level prohibited me from examining or treating her scar tissue or checking for internal trigger points that might have been contributing to her problem. This poor woman had been subjected to so many traumas in the genital region that she recoiled fearfully when I attempted to touch her there, making it almost impossible for me to progress with her treatment. It also made it extremely difficult for the physical therapist to conduct a meaningful evaluation. While Michelle's problem is certainly not all in the head, treatment-induced stress and anxiety are hugely important factors that must be addressed if we are to help her. Her case illustrates how inappropriate treatment can profoundly traumatize the patient and prolong or even derail healing. Hold on. I don't know if you're here or not, but let's do another one real quick, because this might relate to you. Leslie, age 36, came to see me with a laundry list of symptoms and challenging history loaded with stress, the sum total of which left her in a barely functional state. She complained of pain in her left hip and tailbone, lower abdomen, pubis, and upon questioning, pain in her toe joints and numbness in her little toes. She said the pain flared severely whenever she rode her mountain bike, forcing her to abandon this activity. That sitting, which was required for long periods of time at her stressful job, was painful. That walking was sometimes really hard. She also reported suffering from urinary stress and urge incontinence, with the urge to void during intercourse, and that when holding back her urine, she felt pain throughout her pelvis. Additionally, she related a history of painful constipation with intense straining, possibly related to high doses of narcotics she'd been taking. Finally, she described episodes of stunning deep anorectal pain that lasted about 3 minutes, causing her to stop in her tracks, wait with fist clench, and catch her breath when they ended. These painful spasms became more frequent and severe to the point where she feared she could not continue to work. 5 years prior to her consultation with me, Leslie had experienced pain with sex. The recommended treatment was a hysterectomy for fibroid tumors along with a tummy tuck, after which she did well for a year. Then the abdominal pain began, and the doctors evidently thought it was psychosomatic. In her words, they said, they made me feel like I was crazy. Nonetheless, an exploratory laparoscopy was performed and adhesions related to previous surgeries were removed. This relieved the abdominal pain for 10 months, but then it returned and Leslie had had another surgery. Upon examining Leslie, I found trigger points in her hip rotator, adductor, abdominal, and psoas muscles, and also in her abdominal scar, along with extreme pelvic floor tension, particularly in the puborectalis. Also observed were biomechanical abnormalities that include hip height discrepancy, Morton's toes, bunions, and excessive pronation. Myofascial release of the tension and trigger points and the dysfunctional and trigger points in the tender scar gave her significant relief. After only a few treatments, she was able to decrease her pain medication by 50%. Her rectal spasms and other symptoms greatly improved, and she could walk comfortably for an hour 4 times a week. In fact, the last time I saw her, she was feeling so good that she almost canceled her appointment. My exam that day revealed only a few trigger points that required some additional attention. So anyway, listen, this book is insanely good. And I think you need to get this book too. Okay. I mean, I really think it will help you understand the biomechanics. It will help you understand. I mean, ideally, guys, I want every single one of you, when you have a pelvic floor examination and you're laying on that table and they're touching your muscles, I want you to be able to visualize what muscle they're touching by name. And I want you to know where it is. Because, you know, we had this stunning research study a couple of years ago of men diagnosed with chronic prostatitis, and 70% of them had a hip problem. So we always have to think about biomechanics, biomechanical influences on the bladder. Okay, I'm still not allowed to use a straw, so hold on. This is my breakfast and my lunch. This is a smoothie with mango, strawberry, pineapple, fiber, bananas, and raspberry coconut yogurt. Yeah, yum. Hi, Marianne. Okay, so Alina said, so hold on a sec. So your bladder, hold on. I smell something hot. Hold on. I got to make sure nobody's burning something. I'll be right back. I was right. Burn toast yet again. Every single time the 94-year-old burns toast. Okay, Elena, sorry about that. So bladder pain and frequency started 3 days before the bike ride. You were taking high doses of niacin that caused bladder frequency and spasms. I'd be more suspicious of coffee or green tea rather than the vitamin, but it is what it is. So that might be separate and distinct from the pudendal neuralgia that caused by the bike ride. Melissa Dar said, do you know pelvic congestion syndrome has any link to IC? Absolutely. I was diagnosed with this a couple months before getting diagnosed with IC. Yes, many patients have been diagnosed with IC only to discover after the fact that they had pelvic congestion syndrome. And so hopefully, Melissa, you're working with an interventional radiologist to fix that, because pelvic congestion syndrome, which is basically varicose veins in your pelvis, one specific vein or artery is collecting blood, and that heaviness is pushing on nerves, pushing on all sorts of things and causing symptoms. Charlie said, going in tomorrow for another cysto to look for ulcers, a third pudendal nerve block, and a possible TUIP. Nothing seems to help me much. Meds, procedures, supplements, pelvic floor therapy helps for a few days. Anything else you would recommend? Are there any treatments that differ between men and women? I'm frustrated. So Charlie, okay, now what, again, in that study of men with quote unquote chronic prostatitis, which is equivalent to interstitial cystitis, pretty much. They're in the same research team at the National Institutes of Health. 70% of the men who struggled with recurring urinary symptoms had an underlying hip problem. And so you just gave a really big clue here, Hun, because you just said pelvic floor physical therapy helps for a few days. Okay, so if pelvic floor physical therapy helps reduce your symptoms, that's fantastic. But now we have to try to understand, why are you going back into tension? So there are kind of two things that can happen with pelvic floor physical therapy. And remember, a healthy pelvic floor muscle feels like a raw chicken breast. A tight pelvic floor muscle feels like painful beef jerky. Okay, it's thick and painful to touch, whereas a healthy muscle is soft and pliant and it's not painful to touch. So if, for example, your symptoms occurred because of, let's just say you fell really badly once and your muscles went into tension, or let's say you have a foot injury or a knee injury and you're walking all weird and that puts some pelvic floor tension in there. Once we stabilize how you walk and get that fixed, so that's not putting pressure on your pelvic floor, physical therapy should slowly and steadily bring that muscle out of tension. But there are a group of patients who, like me, who no matter what you do, their muscles go back into tension. And that became ultimately the mystery that Dr. Jerome Weiss tried to solve and did solve at the end of his career. It took him 15 years. He was really fascinated by those. So let me take a step back here. Dr. Jerome Weiss was a urologist who back in the 70s and 80s saw that bladder treatments didn't work for the vast majority of patients. And he's a very humble, very inquisitive guy. I've met him many times. So he was probably the first urologist in the United States and one of the first probably in the world to say, maybe it's not the bladder. Let's look at other things that influence the bladder. And so he took every class that he could find on muscles and nerves. And he flew to Asia, you name it, he did it. He was trying to understand the many potential influences that can affect the bladder. And so he became he's up there with Dr. Robert Eckenberg as being one of the top in the world. It's just, unfortunately, he's 85 now and he's retired, but he left us this love letter in this book, right? This book is his love letter to patients. So in his career, he became a master at working with pelvic floor muscles. And so if you walked into his clinic and you had tight pelvic floor muscles, odds are you would walk out feeling much, much better. He was extremely gifted in how he worked with muscles and trigger points. And I know this because I ran the support group here. A lot of our members went and saw him. And I really regret that I never went to see him. I really regret that. It was a huge mistake on my part. Okay, so if you walked in with tight muscles, you would walk out probably with much better muscle tone based upon his work with you. And for the majority of patients, that just continued with every subsequent treatment. The muscles got better and better and better. And 6, 7, 8 treatments later, the patient was fine, fully recovered, and they go on their way. But there was a group of patients who, no matter what he did, the muscles went back into tension, and the trigger points came back in exactly the same location. So the patient would call 5 days later, a month later, 2 months later. He goes, Dr. Weiss, it's back. And he's like, I just worked with you. You walked out of my clinic with healthy muscles. Why are your muscles tight? And that's when he started looking at bones. Because what puts long-term stress on muscles but bones? And of course, we have this research study now that showed that 70% of men with chronic prostatitis had a hip issue. Or, so that makes sense. Or an SI issue, like for me. I mean, I absolutely have an SI issue. There's no doubt about it. Or a tailbone issue. That all makes sense. Or maybe if you have a knee problem, like my knee was really hurting this morning because I did a really long walk yesterday. If you're limping, you're tilting your pelvis in a certain way and you're walking that way, that's going to tweak your pelvic floor. But here's what he found. The most common factor of a patient with long-term pelvic floor tension was how they walked. That if you're pigeon-toed, your toes are together, or you're duck-footed, your toes are apart, or you have an ankle that rolls in or an ankle that rolls out, or if you have Morton's toe, Morton's neuroma. If you have a history of plantar fasciitis, Morton's neuroma, that points directly to something biomechanical happening with your muscle, with your feet. And you have to remember that all of the forces, all of the stumbles, all of that gets reflected from your feet, up your legs, directly into your pelvic floor. And there's a good example of when that happens. If you've ever hit somebody in a head-on accident and you have your feet out, we're on the brake pedal, the forces of that impact go right up your leg and can break your hip. So abnormalities with the feet will absolutely affect your pelvic floor. So I want to see if I can. So I want you to look at this picture here. So look at this picture for a moment. So this is a picture of somebody who has an ankle that's rolling in. So here's a normal, healthy leg. And I want you to see that from the ankle, the shin bone, these bones, straight up, 90-degree angle from the ground. We're going straight up into the pelvis. It's a straight line, right? And if you look close, you can see the piriformis muscle right here, right? So this is healthy. This is normal, okay? Now look at this. This is what happens if you have an ankle that's rolling inwards. So immediately, instead of your shin being straight up and down, you're already at an angle. You're already at a 10, 15, 20-degree angle right here. And look at what it does to the knee. You see that? The outside of the knee, it flexes and gets open. And you can see that angle going all the way up here into the pelvic cavity. So if you look closely, here's your normal piriformis. And see, it's kind of a fat muscle right here. But look at on the other side. Here's a piriformis that's stretched out. Why is it stretched out? Oh, because the bone is pointing away. And it all goes back to the feet right there. So Dr. Weiss's contribution to helping us understand why pelvic floor muscles can stay tight for a long period of time and why something as simple as your shoes and how you walk can cause bladder problems and bladder pain. It's a ripple effect. Hit says, now that you mentioned green tea, I need to mention I was drinking a lot of green tea because someone told me it helped prevent COVID during that time when I started having, oh, dude. Green tea is agony. It is caustic. It is like It's not as bad as ketamine, but literally you're going to have the same effect with green tea that you're going to have with ketamine. It's going to be very irritating. Now, something else that Dr. Weiss talks about is something called Morton's toe. So normally, your big toe is your longest toe. So remember how the human body is designed. The bigger the bone, the more weight it's meant to carry. So your biggest toe is your big toe. And the knuckle of the big toe is a big, big bone. Because your big toe is supposed to carry the weight when you walk. No, normally in a normal foot, what is it, like 80%? 80% of your weight is carried by your big toe. 20% is carried by your second toe. And your third, fourth, and fifth toes are not meant to carry weight. They don't, I mean, they might help you balance, but they're not weight bearing like your big toe is meant to be weight bearing. But there's a condition called Morton's toe. And in Morton's toe, your second toe is longer than your big toe. And so what that means then is that the weight gets, okay, your big toe is supposed to hit the ground first. It doesn't. Your second toe hits the ground first. So what happens is your second toe becomes the big weight-bearing toe. And the big toe is not getting the weight it's supposed to carry because the joint just doesn't hit the ground first. It's the second toe that hits the ground. And then what happens is your third, fourth, and fifth toe and your little toe, they all start carrying weight they're not meant to carry. So when you think of hammer toes are toes that turn like this because they're trying to grip the ground. So hammer toes are a sign that your feet are not hitting the ground correctly, right? So if you got hammer toes that bend down like that, that can be an issue. And so here's a picture of it. So we can see the second toe is longer than the first toe. This joint is longer than this joint. And so when this patient walks, this joint hits the ground first. And that also can be the cause. Oh, here's another picture. This is a picture that's even better. So short, long, right? So you can see this joint is farther along than this joint. And so this joint is going to be carrying the weight, and that's going to mess everything up. And that actually can cause myofascial pain that can begin in your feet, go up your legs, and go up into your pelvis. If you have Morton's toe, your foot is not working properly. This is because Morton toes cause abnormal pronation of the foot. And according to Drs. Travell, Simons, and Morton, overpronation causes many muscles in the body to be stressed or injured, become dysfunctional themselves, and eventually develop painful active trigger points. And some trigger points can refer pain way outside the area they are located. And the amount of pain and suffering they can cause throughout the body is simply astounding. So this talks about, you can make a very simple toe pad. It costs you like $3. I do that in all my shoes because I have Morton's toe. And I think that that's helped quite a bit. That's helped me. I love this book. Oh, here you go. Here, let's do another one. This is Peter's story. The case of a 46-year-old physician named Peter demonstrates how the toe bone connects to the hip bone, connects to the pelvic floor. He came to my office complaining that he'd been suffering for a year and a half with increasing pain in his tailbone, buttocks, sacrum, and sit bones while sitting. The pain had become so excruciating, as high as 10 on a scale of 10, that he was being treated with a potent narcotic and had been forced to modify his medical practice so that it would be less physically demanding. 3 years prior to seeing me, Peter began experiencing severe pain under the right second metatarsal bone. Though he wore a pad under the metatarsal with some relief, his podiatrist said it wasn't the answer and concluded the pain was caused by a short Achilles tendon. In March 2008, Peter had 2 combined procedures, one to lengthen both tendons, and the other to repair the right second metatarsal. This needless surgery only made the foot pain worse, possibly by damaging a nerve. It was then that he began to notice progressive pain in the pelvic region that he complained about when he arrived at our clinic. This had been vaguely identified as complex regional pain syndrome, which refers to pain maintained by the sympathetic nervous system. When I examined Peter, I found bilateral Morton's toes with all the trimmings, meaning calluses under the second metatarsal, bunions over pronation. These related foot findings were most likely the root cause of his pain, having generated the fallout that might be expected. This included trigger points in the gluteus medius, the obturator internus, and the piriformis muscle. And if that were not enough, dysfunctional obturator internus was compressing the pudendal nerve inside the sit bones, causing pain with sitting. The lower fascial margin of this problematic muscle folds over to form. Okay. Given the extensive presence of trigger points and the collateral nerve damage, one can readily understand Peter's pain. After 3 nerve blocks and 4 months of pelvic floor physical therapy, including trigger point release and nerve mobilization, Peter was able to sit for 30 minutes without pain. We had accomplished something, but not enough. On re-examination after clearing the pain, I located trigger points in the iliococcygeus muscles that were the source of the rectal and coccygeal pain. And he goes, this peeling the onion process is typical for chronic pelvic pain. Seldom are all the bad guys found at once. 3 months later, following a series of trigger point injections in combination with ongoing manual therapy, he can now sit for 2 to 3 hours without pain and can use an elliptical trainer for about 20 minutes. However, we still have a way to go. And he believes that he will have a complete and full recovery. Peter's life-robbing experience presents a classic example of how problems originating in the feet, in this case bilateral Morton's toe, can initiate a chain of compensatory stresses that travel upward to the pelvic musculature and the pudendal nerve. This upward mobility of stress, be it compensatory or traumatic, is a theme that runs throughout this chapter, beginning with Dr. Minkowski's example of a rear ender where the force of the impact traveled from the victim's foot up the hamstring muscle of the leg and through the sacrotuberous ligament to the sacrum. Anyway, this book is filled with really good real-life stories. So HIT says, can loosened or tightened pelvic floor muscles cause bladder wall thickness? Well, they're different muscle groups. You know, skeletal muscle is your pelvic floor, smooth muscle is your bladder. I think if your skeletal muscles are tight and restricting blood flow to your bladder, or if you're guarding, you're not moving because your skeletal muscles are so tight, there's going to be a ripple effect. Everything's going to get affected in one way or the other. Marianne says, I owe you a phone call. Is there a day or time that's best to reach out? I would love to talk with you regarding my frequency and treatment. Sure. Hello, David. Hi, Amy. Oh, let me get Dr. Eckenberg's guest editorial. Hold on a sec. Let me get it for you. Because it's brilliant. And it's not long either. So hold on. I just have to log into my cloud account, go into publications under development, 2023, winter. There it is. All right. No, I don't want to update pages. All right. So his guest editorial is kind of in response to subtyping. You know, that what role does phenotyping or subtyping play? And he's responding to the new AUA guideline. There is a large overlap between the UCLA research, which was subtyping, and the newest AUA guidelines. And I find that the model of care I've developed over the past 2 decades is now being shown to be on target through the latest research. In the end, I believe that as in all biological phenomena, whether in a totally normal functioning organism or a pathologic disease state, there are always several things in common. Number one, everything is connected within and surrounding the organism. And number two, there is always a spectrum of and blending of everything that is connected. Therefore, there are innumerable variables to the pelvic pain patient, which makes doing clinical research on humans much more difficult. After all, we have 30 trillion cells in our body, and they all need to function within normal limits for us to feel well. So when it comes to chronic overlapping pain disorders and chronic overlapping inflammatory disorders, which together make up the vast majority of healthcare visits to practitioners in our system, there is a demanding need for the system to recognize these variables. I have now seen close to 2,000 complex chronic pelvic, genital, and sexual pain patients over 20 years and have spent many hours reviewing their extensive lifetime stories in each case. And there are definite patterns or phenotypes that I have observed that closely fit the chronic pain-based model of understanding how the primate organism reacts to pain, suffering, trauma, grief, and loss. I have based my model of care of all chronic pain disorders in the pelvic region on the knowledge that the explosion of neuroscience over the past 3 decades, along with the biopsychosocial approach to these baseline issues of pain and sensory processing disorders, is the best way to validate and help patients understand and therefore be a part of their healing process. Neurogenic inflammation, which has only been described in pain research literature for about 15 years, does link the pain and inflammatory worlds. And this is a very important concept for practitioners and patients to understand. Also, the embryologic derivations of the bladder and urethral linings being the same as the vulvar vestibule helps us to understand the very common connection between IC and vulvar vestibulodynia, and even part of the root cause of the spectrum of hyperarousal disorders. Pudendal and other pelvic peripheral neuropathies are also one of the common denominators in the majority of our patients. Most importantly, the research to date has been much more definitively shown that about 1 out of 5, 20% of the world's population carries a genetic predisposition for developing chronic pain disorders, such as fibro, migraine, low back, TMJ, IBS, IC, vulvodynia, endo, and even chronic fatigue. Now, all of these disorders have certain lifetime experiences in common, including and especially cumulative trauma, whether they be physical, sexual, functional, athletic, accidental, surgical, emotional, or birthing trauma. The pelvic region between the mid-abdomen and mid-thigh is the busiest part of the body and is active 24/7 and is prone to all of these potential traumas. We see more long-term athletic traumas and cumulative overuse and engagement of the pelvic neuromuscular core than patients who have been abused. So I have long looked at IC as just one of many visceral and somatic triggering disorders for complex pelvic pain patients. Many of these triggers overlap. So we have to start with new patients by finding out what their specific symptom might be, which can range from pain triggered with sitting, exercising, orgasm, tampon placement, bowel or bladder function, arousal dysfunction such as dryness, vestibular touch or friction, ejaculation, time of day, time of month, weather conditions, stress, sensory hypersensitivity, etc. In summary, I believe my decades of observation and success in diagnosing and treating complex pain in the pelvic region, even chronic regional pain syndrome, appears to have been on track with the new guidelines. I totally believe that the development of a chemical marker in urine or plasma will make the world of a difference in the ability to do better clinical research. It might even allow urologists to, quote, believe that there is such a condition and that is not just in the heads of middle-aged females, drug-seeking hypochondriacs, as one pain management doctor once told me to my face. Now, that's very academic, but that's what we have to do. It is, as he said, there's just so much overlap. that it's not like there's one incurable bladder disease. You are an anatomical mystery to be solved. And we've got to figure out anatomically what's playing a role in this. Is there physical trauma? Is there sensory trauma? Is there nerve trauma? Is there, I mean, it's just the sky's the limit here. And there's, as somebody emailed me after I sent out my newsletter, they go, well, this is depressing. And I'm like, how is this depressing? This is fantastic. This is going to help so many patients find the underlying cause for their pain when we stop chasing the bladder and start looking beyond the bladder for some of these causes, right? It says, I do uroflowmetry too, and the doc said it was normal. He didn't insist on cysto. So again, it seems like your bladder's pretty good, but obviously there's something going on with your nerves and muscles. We can geek out. I can geek out on a lot of that. Vicky says, amen to what he's saying. Oops. I was trying. I forgot I can't use a straw. Vicky says, I have theories on base causes. He needs to consult with Dr. Michael Grieger. There are a lot of potential base causes. A lot. All right, guys. Now you've all gotten just a little bit quiet. I realize it is a beautiful sunny day, at least out here in California. We're expecting snow on Wednesday or Thursday. We might actually have snow down to 500 feet. So this is probably going to be our last warm day. It's probably 65 outside. Vicky says it's fascinating. It's just too painful. Yeah, it's hard because, I mean, in my brain, I'm 25 years old and I want to go do all the things I wanted to do in my 20s. But I am 62. My body is not the same. There are issues with this body now. You know, I got ruptured disc. Oh, Donna from Germany, girl, how are you? How are you, hun? I hope it's going well. I've been thinking about you a lot. Donna flew to Germany to be with family. Let us know how you're doing. Baby is transitioning. Oh, okay, got it. Oh, close your eyes and just pretend I'm giving you a big giant hug right now, like the biggest hug of all. The biggest hug of all, Donna. Dottie says, my pelvic pain doc wants to do bladder instills. What do they contain these days? I have all those formulas over on the website. Okay, so the most common bladder instill right now is going to be a rescue. It's going to have something to coat the bladder wall like heparin. It's going to have a little bit of a numbing agent in it like lidocaine or marcaine. They might use a little bit of steroid in it, like triamcinolone, and a little bit of sodium bicarbonate. So that classic rescue installation, which is it's a combination of a heparin installation and an anesthetic cocktail, right? That's the combination. By far, the most common treatment around the world for anybody with bladder wall issues. What has fallen out of favor, obviously, are the old bladder installations like, oh, Donna, I'm thinking about you, hun. I'm really thinking about you. DMSO, we don't really do DMSO that much. Because we now know that DMSO can, oh, I need a moment. Hold on. I love you guys so much. And when you're struggling, you know I'm right there with you. Oh, let me get a Kleenex. Oh, the gift of life, the gift of friendship is that we get to be there, right? We get to be there. So these are tears of love all the way. Stop crying. Donna, I know you're crying. Stop it. We're going to get through this together. I promise you. You're a strong, tough woman. Okay, so let's get back to bladder instill. So in the old days, they used to do bladder strippers like chlorpactin and silver nitrate. We don't do that anymore. They're not even mentioned in the guidelines. And number two, DMSO has really fallen out of favor. And one of the reasons why it's fallen out of favor is at the FDA approved dosage. We now know that that can cause bladder spasm. And you know, it's really interesting. I was working, so Renee, you're right. You guys, I'm okay. I'm okay. I'm thinking of somebody. I'm thinking of Donna. I'm so proud of you, girl. I'm so proud of you. We all send you our love. I know, honey. I don't want to say what's going on unless you tell me what's going on, unless you allow me to say that. But, you know, we just want to send Donna and her family all of our love, all of our love for sure. Vicky says silver nitrate. Yeah, man, in the old days, they did a lot of silver nitrate. Okay, so as an example of somebody completely misusing bladder installations, in my opinion, I was working with a patient who for years did home installations with DMSO and whatever else she could get, right? And the doctor just let her do it. And so she could do it every 2 weeks, but not 3 weeks. If she waited 3 weeks, her symptoms started to come back. She had done this for 10 freaking years. And she was clinging to the DMSO, just clinging to it. This is my treatment. And I said to her, I said, you are chasing your symptoms. You are chasing your symptoms with this treatment. You're not better. The DMSO has not gotten you better. It hasn't repaired anything because your symptoms are coming back in 3 weeks, right? And she's like, but that's my treatment. And I'm like, but it's not your treatment. You're chasing your symptoms. You're not fixing underlying cause. And this is before we were doing subtyping. She didn't know about muscles. She didn't know about anything else. And I just, you know, I blew her mind in a way because I think and you know, you guys, I talk to a lot of patients and sometimes you get confused in my brain, but this is very distinct because we just had this conversation a couple of days ago. I think her urologist retired and she went to a new urologist and the new urologist didn't want to give her the DMSO. She's like, what do I do? And I'm like, all right, well, what do the AUA guidelines say? Stop what you're doing, take a step back, revisit the diagnosis. You've done DMSO for 10 years. You're still symptomatic. Why? What's the underlying cause? And then she shared that her bladder is completely healthy on the inside, that they look in her bladder and she was going to let them look in her bladder again. It's like, okay, wait. If your bladder is completely healthy, then maybe what we need to do is we need to put a period on that for a moment. Let's accept that for what this is and try to understand other influences that could do this. Donna says, please feel free to talk about it. I trust you implicitly. Yeah, the community needs to know the relationship between painful events and pain. Okay. Okay. I swear. I have friends in the ICU world who are like my sisters. Donna, you're like my sister. I love you dearly. Her son is dying of cancer, and he's in Germany right now, and he's very near the end. And she got there. She got to Germany. I'm so proud of you. It took a lot of planning. It took a lot of planning because she's got pretty wicked symptoms. We're very similar. I just wish I could just be there with you right now. I do. So everybody, stop for a moment, close your eyes, and just send love to Donna and her family and to her son. Tears of love. Tears of love. Amy says, love to you, Donna, on Facebook. Yeah. Proud military family. Proud military family. He's in the military. And Donna's husband is retired military. Amy Rendina says, love to Donna. Prayers from Denise. Vicky, bless your heart. This journey called life is just, it's just, when you're young, you can't wait to get older. You can't wait to get older because you think life is going to get easier. And then you get older and we work more. And then we have more demands. And, we rise to the occasion. I mean, I truly believe you've never been more prepared to deal with whatever happens to you than you are at this very moment. Because you are truly one day older and one day wiser. I know that I am. And I say this, I say this in the best possible way to everybody. And I try not to be offensive, but I'm a strong, tough bitch. And Donna, so are you. And I say that, I mean, there might be better language for that, but I really, truly think that as we get older, we get stronger. And I also believe that the gift of maturity is as we start to understand the cycle of life and we understand the importance of being with each other. One of the things that I say to patients, who often worry that IC's going to change them, that they're not going to be a good wife or a good mother or whatever just because they have pelvic pain. And my answer is baloney. I was going to say BS, but baloney. Because you know what the gift of this is? The gift of this is that we will never walk away from somebody in pain because we know what it's like to suffer and be in pain, right? We do. And ultimately, in the end, that is the silver lining here, is that I think having gone through personal struggles, it makes you a better mother. It makes you a better daughter. It makes you a better friend. It makes you a better spouse. Because we have to have that humility. Listen, the harsh reality for men is that, I mean, we women, we have to deal with menstrual cramps. Like for me, starting in 4th grade, that was, just dealing with what can be incredibly severe cramping your entire life is very freaking annoying. And for men don't go through that, and they're often very, very puzzled by that. But then they hit the age where they start having prostate problems. And so we all have to be compassionate to each other. We do. Life is fragile. And we're here to help each other. And we're here to strengthen each other. And we're here to encourage each other. And as Donna said here, Donna says, I love all of you. That's why I'm here. And Donna says very correctly, your children dying before you is not the natural order of things. It's not. It's not. I have faith. I have very, very strong faith. And I truly believe that we are all connected. Renee says, oh, sorry, I'm still with my 88-year-old mom. Hey, man, I got my 100-year-old dad and my 94-year-old mom. This is something that I am facing every single day. Every single day. And it's inevitable. It's going to happen. And for my parents, and Donna says, say it out loud, Jill. Yep. Yeah. I mean, having IC and having pelvic pain transformed my life. It was terrible going through it. It's terrible. I mean, I went through a period of time where I didn't feel like I deserved to eat. I certainly didn't deserve to go out to dinner with my parents or my family in my 20s when I had the IBS and all that sort of stuff. I mean, I really thought I was being punished. My self-esteem was in the door. It was out the door. My self-esteem, I had no self-esteem back then. I was just damaged goods. But then we had the research. We had new research that happened. So we first had research that talked about genetics. And I'm like, well, wait a second. It's like my dad totally has stomach problems. He's had them his whole life. He's had heart issues. I happen to inherit his heart stuff. My mother has always had bladder stuff. My grandmother always had bladder stuff. My aunt, my cousin, wait, what? You mean I didn't cause this? It's not my fault? I could have inherited some of this? Sensitivity, IC subtype 5, central sensitization, redhead, hello. And then we had the research that talked about how nerves talk to other nerves, that when the bowel gets irritated, the bladder gets irritated, and the bladder gets irritated, the bowel gets irritated, and all the nerves can get irritated. And that's like, okay. And so they started talking about central sensitization. And it's like, well, wait a second. I have really sensitive skin. I have a wicked sense of smell. I can hear everything. It's crazy sense of hearing. What the hell is that? Oh, wait. You mean everything I have is because of my nerves? You mean it was never my fault? Oh, giant weight off the shoulders, my friends. My self-esteem is just fine now because it was never my fault. I am not damaged goods. And probably the most important moment happened was when I went to an emergency. My pain was so severe, and you guys, I'm pain-free now. The vast majority of the time, I'm pain-free. I'm a total success story, okay? But before we knew all this, I was, back when we thought it was an incurable bladder disease, I was at the emergency room 2 days in a row. And the ER doctor said to me, you will forever be a burden on your family. This is life. Get used to it. You will always live with severe pain. And I was like, I was sitting like this and I went, what? What? Wait a second. I have 3 college degrees. I have an award from the White House. I will prove you wrong, you son of a bitch. How dare you say that to me? That's exactly what I said to him. First time I've ever sworn at a doctor. It's the rudest thing anybody could have said. You will forever be a burden on your family. Bullshit. And I went home and I started studying. What's my favorite affirmation? Be bold and mighty forces shall come to thy aid, right? Okay, man. I called researchers. The ICA was furious with me. They were like, who the hell do you think you are to call a researcher? Like, I'm calling anybody I want. And that's how the IC network was born. And it was that moment when I decided to take my life back. I was not going to live with depression. I was not going to live thinking this was my fault. I was determined to prove those people wrong. And they were wrong. And he was wrong. And I have been symptom free, other than my SI joint acting up every now and then, for my bladder. You know, a long time ago. So hold on here one second. Amy says, it feels like punishment. What did I do to get Ehlers, mast cell, heart issues, classic IC, and now chronic migraine and pregnancy? I mean, girl, that's exactly how I felt. Exactly how I felt when I was 28, 29 years old. I don't know how I finished grad school. That's exactly, and especially the heart issues. The heart issues, because nobody, that's scary stuff. Bladder not as scary as heart stuff. And nobody like holds your hand and explains things to you. So you have to understand, number one, you didn't do anything wrong. This is absolutely not your fault. Ehlers-Danlos is not your fault. Mast cell dysfunction is not your fault. Your heart issues are not your fault. Classic IC is not your fault. None of that is your fault. You got hurt in some way. Your immune system maybe got hurt. Your nerves got hurt. And so what do we do now? What do we do now? We have to, on a daily basis, work on as much as we can. We got to keep our muscles calm. We got to calm our nerves down. We got to work on our state of mind, because the more anxious you are, the worse things get, right? Donna says, thank you for your prayers. Yeah. It's a journey. And I always liken it to building a house, man. You don't just build the whole house in one day. You build a brick. And especially for those of you who, are addicted to coffee and things like that, this can feel very difficult. Here, let me go get a hairband. Hold on. See, I'm having one of those super irritated days because allergies are just insane. We're all annoyed. We're all annoyed right now with allergies, and now my skin is kind of a little funky. Let me just get my hair up so I stop messing with it. All right. Oh, so much better. All right. Hitatsu says, Donna says, I love you more. Hitatsu says, with urinary incontinence urgency issues, are the pelvic floor muscles loose or tight? Well, they're often loose. Incontinence can come from very, very loose muscles, but incontinence can also come from nerves that are being tweaked. So we got to get, are you in Japan? What country are you in? I might be able to help connect you if you tell me what country you're in. Does pelvic floor therapy help? Girl, of every research ever studied, every treatment ever studied in IC, the single most effective treatment by far is pelvic floor physical therapy. Vicky says, what book was I reading from? Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss. Go to the IC Network store. It's on the front page. There's 2 books. There's really only 2 books we recommend now. IC 101, it's not just a bladder disease. And then for those of you who have weird muscle nerve things going on, this book. This is a master class. It's wonderful. Amy, I would love to talk to you at some point in time. If you'd like to give me a call this week, I think it would be, I mean, I really, really, really want you to know that you're not alone. You're absolutely not alone. I think your thoughts are reasonable given what you've gone through, but we have to change them now because you're not being punished. You've just been injured in some way, just like I've been injured in some way. And that doesn't change your character. That doesn't change your person. That doesn't change your spirit or your soul or anything like that. What we have to do is work on that injury. And that's the challenge of getting older, is we all have kind of funky, weird things going on that we've got to be attentive to. Technically, every day, I should be walking. I should be doing my pelvic floor. I should be doing my low back and my leg exercises. I should be doing my TMJ exercises, and I should be eating well. And I do eat very well, but it's all about discipline now. And it's hard to be disciplined when life is so busy. Life is so busy right now for all of us. Oh, you're in India. Okay, so did you know that there's an Indian IC organization? I just spoke for an Indian IC conference last August. There is an Indian outreach group, and one of the top doctors in India is named Nagendra Mishra. He's a lovely guy. He's really nice. Nagendra Mishra. So let me look on my website. I have the contact information for the new, it's run by a lady named Balaka Basu. I think I got that right. Hold on. Is it Balaka or I think that I might be wrong. Balaka might be another country, but hold on. Let me take a quick look real quick. No, I'm right. It's Balaka Basu. And they have a website. Hitatsu, let me put the link for them in the meeting. So hold on a sec. I can get that for you. So this group has been around, I don't know, 5-6 years, maybe a little bit longer. And they're playing a very, very important role in the international IC community. Balaka is one of the leaders of the international group that I'm a member of. You know, we're long past the days of thinking that an American group should lead the world. No, come on. We have to allow and respect and honor the skills and talent of IC patients and groups around the country, around the world. And there are some amazingly talented people. I have to kind of hold myself back a little bit. Okay, so here is, it's interstitialcystitisindia.org. So you can reach out to Balaka here. Doesn't look like they've updated their website during COVID, but anyway, give it a shot, hon. Yeah, BALA, not BILA. It's BALAKA, Balaka Basu. Sally said, are bladder installations appropriate for occasional flare-ups, or would pain meds suffice? My urologist insists I do installations for flare-ups, even though I only get them once in a while. Well, you know, if you're having a bladder wall flare or a Hunner's lesion flare, a rescue installation is actually ideal because it's putting the anesthetic directly onto the bladder, where it's going to numb those tissues. So I think if you respond well to those bladder installations during flares, I would do them. I don't have an issue with them. But you never, ever, 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 ever allow anybody to put something in your bladder without telling you what's in it. You can't just go in and say, give me a bladder instillation. You gotta find out what they're doing. We want to make sure that they don't accidentally put something bad in there, right? And Dottie says, pain meds are not touching this flare. Dottie, do you know what kind of flare you're having? Is it a bladder wall or pelvic floor, stress, hormone? What kind of flare do you think you're having? Because there are lots of different types of flares. And when did your flare begin, and what do you think triggered your flare? PK says, I'm always getting UTIs as part of IC. No, if you're always getting UTI, that's probably the result of estrogen atrophy. Dottie says, my pelvic pain doc has IC, so I trust her. You guys just remember that the term IC doesn't really mean anything anymore. In Europe, they are not going to be using interstitial cystitis or chronic prostatitis at all because they incorrectly suggest that it's a bladder disease when it's not. They're calling that instead a pelvic pain syndrome. It might be a bladder primary pelvic pain syndrome, something like that. So the name interstitial cystitis is eventually going to go away. The reason why it hasn't yet is because, I mean, here in the United States, we have our IC guidelines for Social Security. And the fear and worry is that if we stop using the name interstitial cystitis, people will lose their disability insurance. You know, it's going to take years to get Social Security to update those guidelines to call it bladder pain syndrome or chronic pelvic pain syndrome. So don't just keep saying IC. What you have to say is, go beyond that. Okay, what's hurting? Is it your bladder or is it your pelvic floor? Yeah, Dottie says, I use IC. Well, yeah, I do too, hun. Okay, so let's see. You don't know the cause or the type of your flare. Guys, if you go over to the IC Network website, which is icnetwork.org, if you sign up for our free newsletter, and I do not send out spam emails at all, you can download our 40-page free flare management guide, which has hour-by-hour rescue plans. So that will help you figure out the type of your flare that you're having. Okay. Dottie says she checked your pelvic floor and it was fine. Okay. So now we have to figure out why you're in such severe pain. Do you have Hunner's lesions on your bladder that need to be treated? Maybe. Kelsey says, what is helpful for an IBS flare? How to calm the cramps without creating more constipation? Fiber. What I use is this. A soluble fiber. So a soluble fiber is a fiber that dissolves in water, and an insoluble fiber is a fiber that stays rough. So an example of an insoluble fiber is granola. So it's very rough on the gut. And for those of us who have IBS, we have very sensitive nerves, right? That's part of IC subtype 5. And so Heather, this is Heather's tummy fiber. Heather has a fabulous website, helpforibs.com. She started her website right around the time that I started the IC Network. So we became friends, along with the lady who started Histro Sisters. We were three women who had started websites. It became pretty big. And we all went in different directions. So she ended up creating this line of fibers that are very gentle. One of the things she taught me about IBS is that, number one, there are different types of fiber, soluble versus insoluble. Insoluble fiber, like the fiber that comes in granola, is too rough. And so as it moves through your bowel, I mean, listen, you'll have a big giant bowel movement, but it'll be uncomfortable as hell because it's prickly and it irritates the nerves in your intestine. Whereas Soluble fiber is gentle fiber. Soluble fiber is fiber that dissolves in water. And so it's much more gentle. It does exactly the same thing. It helps things move along, but it doesn't trigger. It doesn't trigger badly. So incorporating this, something like this is important. I don't have IBS flares anymore really because I don't eat the foods which will trigger a flare. So doing an elimination diet can be quite helpful. For me, the foods which trigger bowel spasms were chocolate and oatmeal. Once I stopped the oatmeal, 90% of my IBS went away. And it turns out oatmeal, I've worked with many patients who have problems with oatmeal. So doing that elimination diet to maybe remove your grains other than rice for a couple of days and then reintroducing fibers one at a time to see if there's something you're eating that you think is healthy that is actually causing a problem is important. And Kelsey, if you'd like to talk, feel free to give me a phone call, girl, because I've been through that. I called my bowel spasms bend over and screamers. And I had them for 3 years in my 20s until finally I did an elimination diet. And 24 hours after I stopped the oatmeal, the vast majority of them stopped. It was stunning. Then I ate the oatmeal again, and I had the bowel spasm again. So figuring out those foods that are irritating are important. Okay, hold on a sec. Can SI joint osteoarthritis degeneration affect the pelvic floor and in turn trigger IC symptoms? Yeah, definitely. Definitely, because your pelvic floors have to work harder to hold the joint together. So that's you're putting your pelvic floor muscles into tension, into higher levels of tension. That higher level of tension is now going to start restricting blood supply to the bladder. You're going to enter a state of ischemia, which is oxygen deprivation, nutritional deprivation, because you don't have good blood supply to your bladder because your muscles are so freaking tight. And that would cause the bladder wall to not be strong. If your bladder is supposed to get 24 units of blood a day and it's only getting 10, are you going to have a healthy bladder wall? You're not. You're not. That is why we subtype. And that is why when we find pelvic floor dysfunction, we want to get it treated quickly. We've got to restore that blood supply in there because that's going to help your bladder heal. Hitatsu says, I love bitter dark chocolate. I don't eat chocolate. I might do white chocolate. I might do yogurt chips, but I don't eat. You couldn't pay me to eat chocolate. Listen, I went from having bend over and screamers every day for years before. I mean, my doctor kept saying, eat fiber, eat oatmeal. Believe me, I was eating oatmeal every day, all day. Not having a flu, I had a problem with oatmeal. Oh, hysterical. So between the oatmeal and the chocolate, I have no desire to go back and relive that life. I mean, I might every now and then have a little bit of tiramisu with a little bit of powder, a little tiny bit of powder sprinkled on top, but I don't do hot chocolate or anything like that. And you guys, but I do carob. Carob is an alternative to chocolate that is insanely good, and it does not have the allergenic effects of chocolate. So all the carob stuff in the IC Network shop are on sale, 15% off through the end of the month. Because we can't ship it in the summer. So we've got carob brownie mix, we got carob cake mix, we've got carob oatmeal cookie mix, we've got carob chips, we've got carob candy bars, you name it, we've got them. And they have to stay 20 miles away from where I am, because if they're here, I will eat them all. Because they're that good. Angel said Missy's carob brownies. Exactly. So there it's 15% off. The Missy J's carob brownie mix is to die for good, and it won't trigger you at all. Prasid says, what do I do for SI joint degeneration? Well, you got to hold the joint together. This is what I do. I got my SI belt on. As soon as I put my SI belt on, it stopped hurting. You know, they can do something like prolotherapy where they inject an irritant into the tendons and the ligaments around the joint. No, the ligaments around the joint. And that, because the ligaments get stretched out. And that's one reason why the SI joint's flopping all over the place. When you inject it with an irritant like saline water, um, the ligament toughens up and gets strong again. It does. Phyllis says, I heard recently that arginine can cause cancer. I'm currently getting pelvic floor therapy, but still have issues, mostly urgency. I was trying to wean off bladder rest and allopath, shoving in PEA. However, the urgency is coming back with a vengeance. Is there any truth to L-arginine problems? Is it safe to use bladder rest and allopath? L-arginine is an amino acid that has been studied, gosh, I'm going to say 20 to 25 years ago. We had our first research with arginine and IC. And I interviewed Dr. Lori Berter at the University of Alabama, who is involved with that arginine research. It turns out that arginine is broken down into, I think, nitric oxide, which is then essential for urination. And you could probably find that transcript on the IC Network website. I have about 100 old guest lectures. She was in our guest lecture series. So for the arginine IC studies, there were 2 studies that were found where it was found to be quite helpful. And there was 1 study where it was found not to be helpful. So now subsequent research has also emerged about the beneficial effects of L-arginine. And I don't really remember what those are off the top of my head. Let me go to PubMed here real quick. L-arginine, so this is from the Mayo Clinic. L-arginine is an amino acid that helps the body build protein. Your body usually makes all the L-arginine it needs. L-arginine is also found in protein-rich foods, including fish, red meat, poultry, soy, whole grains, beans, and dairy products. As a supplement, L-arginine can be used orally and topically. It can also be administered by IV. Because L-arginine acts as a vasodilator, opening or dilating blood vessels, many people take oral L-arginine to treat heart conditions and erectile dysfunction. So here's the evidence. Angina. Studies show that L-arginine might decrease symptoms and improve quality of life in people with mild to severe angina, chest pain. High blood pressure. Some research has shown that oral L-arginine can lower blood pressure in healthy people, people with mild blood pressure elevation and diabetes, and in people with a type of blood pressure that affects their arteries and their lungs. High blood pressure during pregnancy, preeclampsia, erectile dysfunction, and peripheral arterial disease. So the Mayo Clinic says, here's our take, generally safe. L-arginine is considered to be generally safe. It might be effective at lowering blood pressure, reducing the symptoms of angina, and treating erectile dysfunction due to physical cause. However, if you take a blood pressure drug, talk to your doctor before using L-arginine. Oral use can cause nausea, abdominal pain, diarrhea, bloating, gout, headache, allergic response, and inflammation, airway inflammation. It's not recommended for people who have a recent heart attack. It can worsen allergies or asthma. And be careful taking L-arginine if you have cold sores or genital herpes. Too much L-arginine in your system can potentially trigger the virus that causes these conditions. So I'm going to copy this article. This is from the Mayo Clinic. So Phyllis, check out that article. So, but let's talk for a moment about what. So you've stopped the chondroitin-based supplement and the aloe, and you're subbing it over to PEA. So I think you might be mixing methods of action here. So if you have, for example, estrogen atrophy and your bladder wall is getting dry, and so your bladder wall is now compromised, right? Using something that will provide a coating effect is beneficial. But of course, the first thing we do is, if it is related to estrogen atrophy, it's using estrogen. Like, the most important thing to use is estrogen, because when you give that skin estrogen, it immediately improves and starts producing its own mucus. So for somebody with estrogen atrophy that's affecting their bladder, number one is going to be estrogen. But you're never going to have a 20-year-old bladder anymore. And so doing something that has a bit of a coating effect makes sense. And I think that that's why Elmeron shined, because Elmeron is basically the equivalent of a chemical Band-Aid. But the problem, of course, with Elmeron is that it's now linked to pretty severe eye disease. So that's really fallen off of favor. So many patients have transitioned over to chondroitin-based supplements, because there's no other traditional pharmaceutical that does what Elmeron does. So once Elmeron's off the table, there's nothing else that does the same thing that can be prescribed for you. But there are supplements that contain chondroitin and bladder installations that contain chondroitin and heparin that have the potential of coating your bladder a little bit and protecting your bladder. And bladder rest is kind of the starter formula. And allopath, just like aloe is soothing to a sunburn, aloe can be quite soothing to the bladder if you can tolerate. Not everybody can tolerate aloe. Sometimes for some people it can cause a little bit of gut distress. But aloe is not what I call constructive to the bladder. The bladder wall is not made of aloe. Aloe, it comes from a plant. And so chondroitin makes more sense than aloe. But if you're having a flare and we're trying to calm things down, then aloe certainly makes sense for short-term use, but not necessarily. At least that's my thinking. I think that I value chondroitin over aloe for helping the superficial integrity of the bladder wall. PEA, palmitoyl ethylalamide, PEA, targets nerves. So the general consensus among the researchers is that's very good at calming nerves down, which is why I take that. I have a healthy bladder. I don't need to take a chondroitin supplement. My nerves are extremely sensitive. So I choose to take the PEA, and it's worked really, really well for me. So the fact that your urgency is coming back is telling me that you might need that coating effect more. So why did you decide to go from a coating effect to a nerve calming effect? That's the question. You know, and I'm not a more is better person. I don't believe in adding more and more and more and more and more. I mean, you make companies rich, but I don't like that. For me, I don't like adding more. I'm sensitive. I want to find the product that's right for me. And every now and then I have a patient who's like taking 10 or 12 supplements. Like, why are you doing that? Why are you doing that? And they cross purposes, you know. And to step away from the supplements for a moment and just think about mechanism of action here. What are we trying to accomplish? Because if you have tight pelvic floor muscles, supplements are not going to fix that. And if money's tight, don't put your money in supplements. Put your money in pelvic floor physical therapy. Phyllis says, you're just looking for relief. You're currently on estrogen. Well, the fact that you're on estrogen tells me that you have estrogen atrophy. So it tells me you're of my similar age. So I don't know if I agree with that change you're making. I think what you could do is, why don't you combine it? Why don't you try Bladder Builder, which has the chondroitin combined with a nerve calming effect? Bladder Builder might be interesting to try, and that might save you money because it puts it all in one. And then you can save the allopath for when you have flares, right? But if you say you're looking for relief, so it sounds like you've been struggling for some time. Are your symptoms going up and down, or are you just stuck up here in a flare? Hitatsu says, can chronic cystitis cause bladder cancer? Not that we know of. There's no connection between IC and cancer at all. The number one cause of bladder cancer is toxic chemical exposure, usually cigarette smoke. So I'm not worried about that at all, Hitatsu. You know, I had something interesting happen last week. I don't feel well if I eat a big breakfast. I just don't. You know, the way, I mean, on one hand, having a good breakfast helps you have a bowel movement. That's a gastrocolic reflex. So food in, poop out, food in, poop out. That's why, you know, you don't normally have bowel movements before you eat. You have bowel movements after you're done eating. But there are, and my perfect breakfast is going to be a smoothie, or it's going to be a couple of pieces of Ezekiel bread with almond butter. I'm fine. If you give me cereal in the morning, I'll be nauseous all day. I do not do well with any cereal. I just don't. I can get away with, I often make gluten-free pancakes. I'm fine with that. So last week when I was doing the meeting, I made the mistake. I ordered breakfast for my parents. And I made the mistake of eating the biggest breakfast I'd ever eaten before doing one of these meetings. And as I was doing the meeting, I was feeling very crampy. And it just reminded me that the way my body is hardwired, it likes food at the end of the day. It doesn't like food so much. I do little bits here and there and I'm fine. But a big meal in the morning, I will end up being bloated and gassy and irritated all day. Bobby says, I like Bladder Builder because it has a lot of useful components. Yeah, I think Bladder Builder is the best supplement on the market right now. Sue says, I never could eat breakfast in the morning, even as a child. It made me nauseous and I would be sick by the time I got to school. Sue, exactly. Oh my God. You know, and the worst is cereal. Doesn't matter what the cereal was, any of the cereal, man. And even I had, like, I tried to have a little bit of, no, wait, what did I try to eat? Rice Krispies, organic Rice Krispies. Because you're thinking rice, super good, but you know, it's got BHA and BHT in it. I think it's the preservatives. I just do not do well with white flour products and heavily preserved products. I will be sick and nauseous all day and bloated and gassy. So Sue, we're sisters, girl. We're sisters. Angel said, funny, I just had a piece of toast with almond butter earlier. Yeah, man, you know, listen, Ezekiel bread toast, although right now I'm microwaving it rather than toasting it because I'm not supposed to chew much. Because it still hurts, you know. I had my second extraction right here. Dental cleaning gone wrong. The hypersonic fractured the roots of my two molars behind my eye tooth. They're both gone. And it's still quite tender to touch. It's okay. It feels better, but it's like right here. I was eating a banana. I bit down on a banana and I just about screamed. It was like, no, that's too hard. I'm not supposed to chew on this side for 2 weeks. Angel said, for breakfast growing up before school, carnation powdered milk drinks. Yes. And oh my God. And what was the other thing we used to drink? The chocolate milk mix? We'd come home from school and we'd have that either strawberry or chocolate milk. What was that? No, there was like a couple of really weird hot chocolate mixes, but it wasn't hot chocolate. It was something else. Like, oh God, what is it? I can taste it right now. Oh my God, I've got this awful taste in my. So that's so funny. The memory. Yeah, the Nestle Yoo-hoo. No. But there was one. Oh my God. It started with an N, but it wasn't Nestle's. Oh, what was that? It was like a powdered protein drink. No. Hot instant drinks. Ovaltine. That's it, Arlene. Ovaltine. That was it. Oh my God. That brings back some memories. Ovaltine was, and then what else did we have? Um, do we have like powdered? Wait, we had Kool-Aid, powdered Gatorade. I mean, this was way before the Crystal Lights. Oh, Elkie, thank you. Tang. Instant orange. I can taste it now. I like Tang. Tang was okay. Tang wasn't too bad. Oh, that's funny. Tang. Ovaltine was just, it was an acquired taste. And you know, the other thing we used to do is we used to heat up Dr. Pepper on the stove and put a slice of lemon in it. Sue says, cashew butter less acidic than almond butter, which I find out because I also have a hiatal hernia. And if any other nut butter will come up on me. Now, see, and now, oh, and malto meal, right? Oh, Marie, thank you so much for the 200 stars. I don't do peanut butter well. Peanut butter gives me GERD. Peanuts seem to give me GERD a little bit. I can do almond butter and I'm gold. The last time I had cashews, it gave me GERD. I really love Brazil nuts. I really love the kind of bitter flavor of Brazil nuts, but they're salty. They're salty, and I'm not eating salt now. Sue says some can't do peanut butter with GERD or the hiatal hernia, right? Angel says it's a fungus on the peanuts. It could be. Could be. Did you guys hear, speaking of peanuts, that former President Jimmy Carter is in hospice care now? He's a good man. His entire life building homes for low income and the homeless. You couldn't ask for a better role model of just being a decent, kind, caring human being than Jimmy Carter and Rosalind Carter. I know people disagree about politics. We're not talking about that. We're talking about a legacy. Yeah, as Amy said, I would imagine that we'll lose him very, very quickly. He must be right there. Sue says Brazil nuts will break your teeth. I know, like, no, I like not eating. The hardest thing I might eat is my little xylitol dry mouth thing. But yeah. Renee says worked hard for Habitat for Humanity. Exactly. Walnuts and pecans are good for you. I love pecan. I can do pecans, but walnuts make my my mouth hurt. I don't like walnuts. I mean, I might have walnuts every now and then, and in a cookie, but walnuts actually make my throat burn. There's no swelling or anything like that. And I just think that when we think about the concept of evolutionary adaptation, our bodies were designed by, ancestry 20, 30, 40, 50, 100 generations ago. And so, I am virtually 100% Scandinavian, Swedish, Norway, Finnish, but I'm 95% Swedish and Norwegian. And my family comes from the Arctic Circle. There were no walnuts up there. So, of course, that explains why my body doesn't tolerate walnuts and chocolate and oatmeal. And I'm a terrible Norwegian because I hate fish. Dottie says, a guy on Twitter said, when Jimmy Carter gets to heaven, he's probably going to try to get air conditioners for hell. Oh, that's sweet. That's really sweet. We need more men. And it's just really, And Sue says, Polish, Scottish. Wait, honey, you do know where they all got their red heads, right? And that's from the Vikings, and I'm a Viking. The Vikings, conquered and pillaged and raped, and that's why there's so much red hair in Scotland and Ireland. And oh, Renee says, laugh out loud, I love smoked salmon. Oh, Donna says, Swiss miss. Dottie says, he's that good, he might get it. I just think we really have to, we're really at a reckoning. I mean, we all have to understand that the health that we have today is a direct reflection of our lives today. It is. And I think that the last 6 years here in the United States have been devastating. Just because of all the fighting. It doesn't matter what side you're on. The fighting and villainizing and is never good for the soul. And social networking. I'm just going to flat out say maybe 2% of social networking is healthy. There's so much meanness that's going on the internet. It's heartbreaking. I started the IC network in 1994, early 1994. And that was when the internet was academic. We didn't have all this fighting. We didn't have social networking. We had institutions coming together to share ideas, and it was generated out of it was productive. It had the right spirit. It wasn't weaponized. It was this is why I built the IC network, to give you a free resource for all things IC without having to pay a penny for it. And 30 years later, we're still rated #1 by Harvard Medical School. Or Harvard Institute. Well, not Harvard. No, I might be wrong. Well, Harvard did the study, but there are so many different divisions of Harvard. And so we've gone from this really philanthropic, important exchange of information, working together, to this entertainment culture thriving on putting people down. And it's disgraceful. And it's sad. It's not healthy for us. Hitatsu said, thank you, Jill. I have to go now. We'll check out the Indian group. Honey, anytime. Please reach out to me. Dottie says, I dearly love my immunocompromised deficient buds on Twitter. Yeah, but Twitter's changing. Dottie says, just block the meanness. It's hard. It's hard to block it because Twitter was a safe place until they changed the algorithm. Now we're getting all this weird stuff on Twitter. I've just kind of for my own sanity, because I'm under such stress. This is what I do. I do Wordle. I do the New York Times games. Every now and then I do games on another web, like a little 5-minute game. I am obsessed with watching customs videos from Canada and Australia and England. People trying to bring all these crazy things into countries, like, oh, I didn't know I had a suitcase filled with blood from bleeding meat that I'm not supposed to bring in. I'm currently obsessed with those videos, the little 20-minute videos. But I'm not doing TikTok. I really, truly think TikTok should be banned right now, even though we have IC accounts on TikTok. I think that the Chinese government is up to something there. But I'm not obsessively reading Twitter and Instagram. I'm not. I go over to LinkedIn because a lot of doctors are on LinkedIn. Yeah, Dottie, spelling bee is hysterical. I love doing spelling bee. They give you 7 letters. 1 letter has to be in every word. And I'll go back and forth to that. I almost got all of them a couple of nights ago, but the last night I could only get 5 words. It's like, wow, that was hard. Amy says we didn't need cell phones growing up. I agree. But, Sue says, how many of you are sensitive to chemicals that make your bladder hurt, like fertilizer or nail polish remover or cleaning products? They'll put me right in a flare, and my problem is tight. I have pelvic floor muscles and sensitive nerves. Me too, hun. Getting all those chemicals out of your home is just so incredibly important. Did I tell you my last big chemical drama that had the fire department here? I had spilled, I don't remember what I spilled on the garage floor, but I spilled, just a small little area. And I was using soap and water to get it up. It was something very benign, right? And my dad, who was in World War II, who doesn't have a fear of chemicals, decided to wash the garage floor in turpentine. So my little tiny thing became a huge thing of turpentine. And he comes walking in and he's oozing turpentine out of his pores. And I'm sitting here and I look up and it's like, what did you do? Oh God, you can see my missing teeth. Okay, well, anyway, what did you do, Dad? What did you do? What happened? And he's like, hey, Ma, I'm cleaning your spot. I used some turpentine. I go out there, wet turpentine everywhere. And it's on his shoes. He's walked through the house. Oh, yeah. So what had happened is that I had put baking soda to clean up the spot on it. And he did not understand the baking soda caused a chemical reaction with the turpentine. And so I'm looking at this going, oh my effing God. Right outside the back door. It's coming in the house. So I get out there with a scrub brush and a hose and I scrub it down. Try to get rid of it. And then my chest got tight. And Dad thinks I'm over exaggerating everything. It's like, oh, you're just reacting. It's not a problem. We use turpentine all the time on the ships. It's fine. And so I get most of it gone. And now I'm sitting there and I'm going, and I'm having trouble breathing. And I was like, Dad, did you not see the baking soda on there? He's like, no. It's like, oh, great. Now we're having a toxic chemical reaction. So then we have to call the fire department. So the fire department comes out. And they pull me immediately to the truck. They're like, okay, you're having a reaction to the function. I was like, yes, I know. I'll be okay. I promise. They're like, ma'am, you need to sit down. We probably need to take you to the hospital. Say, I'm fine. I'm just sensitive. I'm fine. And then I calm down and I start breathing normally. I'm like, okay, I'm okay. And they're looking at me like I'm a nut. And then it's like, guys, I'm a chemist. I've got 2 degrees of chemistry. I'll tell you exactly what happened. And they go, oh, yeah, that was bad. Anyway, so, for God's sake, if you're sensitive, please don't have any turpentine in your house. Do not let the elderly try to clean anything. And he just did it again. He tried to use something like airplane glue to glue something in our drawer that stores our forks and knives. And I'm like, what did you do? Anyway, well, listen, guys, obviously I'm willing to talk about anything, but do you have any questions I can answer for you? Sue says, I just got a warning from Facebook because I mentioned Brazil nuts. I don't understand why I would get that warning. Oh, that's weird. Thank you for Renee. Thank you for those stories. Oh, girl. If you only knew. I have been the other thing that's been going on is my mom's been having trouble lifting herself up out of bed. And so I made the mistake of grabbing her with straight arms and pulling her up. And I strained all the muscles from my shoulders down to my waist. And I'm like going, okay, is this my heart? Okay, well, this hurts. And then I start touching. It's like, oh God, every muscle hurts. I did this big walk yesterday up some really tall hills, and I'm just like charging away going, I'm going to go for it. It's just my muscles. And it was just my muscles. It's not my heart at all. It's fine. Be bold and mighty forces shall come to thy aid. Okay. Any other questions? Any other questions? If you don't have any other questions, I think what I'd like to do is read the next chapter in our book, IC 101. So let me pull it up. Because I'm trying to read a chapter. I'm trying to get through the whole book. So give me a moment. And if you want to stay, that's fine. If you want to go, that's fine too. But IC 101 is the top IC book right now. And I'm a co-author of that. All right. Hold on. I just have to find it. Okay. I'm going to publish PDF file. That's what I need. All right. Here we go. So this is our book, IC 101. It's not just a bladder disease, a complete guide to IC, bladder pain syndrome, chronic pelvic pain, and chronic overlapping pain conditions. And if you haven't seen it before, it is this book. It's available on Kindle for $9.99, available as a PDF file on our website for $9.99, or you can get it in print for, I think, $24.99 on our website. All right. Let's go to the next chapter. So I think the last chapter we read was symptom. Let's see. Symptoms and diagnostic methods. So let's get this one down. You know what? I don't think I read this one. I want to get it right. No, I swear I read this one. Hold on. Maybe I didn't. All right. Here we go. Chapter 2, Symptoms and Diagnostic Methods. What's in a name? There is considerable debate about what this condition should be called. I swear, didn't I already read this? Tell me if I already read this. I don't remember. There's considerable debate about what this condition should be called. In the earliest of days, it was known as tic douloureux of the bladder, interstitial cystitis, and cystitis parenchymatose. In the 1990s, researchers in Europe believed that the name should reflect pain and began using bladder pain syndrome or painful bladder syndrome, specifically for patients who struggle with lower urinary tracts who do not have visible lesions on their bladder wall. Asian researchers focused on the sensitivity of the nerves in the bladder and began using the name hypersensitive bladder syndrome. And to make matters more complex, the U.S. National Institutes of Health also uses the name urologic chronic pelvic pain syndrome. So why didn't the USA make the same changes? Well, IC advocates were deeply concerned that changing the name would undermine insurance and disability coverage. The USA took the middle road and combined the acronym of IC with BPS, and more clinicians are choosing chronic pelvic pain syndrome rather than IC-BPS as a diagnosis because structures outside of the bladder can also trigger bladder symptoms, and the name will undoubtedly change again in the coming years. So what does an IC bladder look like? In 1915, Dr. Guy Hunner used the first cystoscope to look inside the bladder, where he found ulcers on the bladder wall in some but not all patients. Now known as Hunner's ulcers or Hunner's lesions, these large red wounds often have a star-like appearance with red arms that radiate from the center. They are known for bleeding so profusely during a hydrodistension that it is described as a waterfall effect. At that time, it was assumed that every patient with interstitial cystitis had these lesions. In the 1940s, as technology and testing methods improved, Dr. J.R. Hand found that found something different. He described, quote, small, discrete submucosal hemorrhages and dot-like bleeding points that were called glomulations. He and many others believed that these more accurately reflected IC. And let me get pictures so you can see that. Here. I think it's helpful to have pictures at the same time, don't you? Okay. So a Hunner's lesion looks like this. There's usually a center with stars, lines that radiate out. And these Hunner's lesions often have a coagulum, a center point. That's basically, you know, like a blood clot, coagulated blood, right? So these are examples of active Hunner's lesions, and these are examples of lesions which have healed. Well, wait, do I have that right? Hold on. Oh, wait, okay. Here's some more. Hunner's lesions, severe inflammation, and here are the ones that are not inflamed anymore. See, they're areas of white, right? Now that's very different from this. So Dr. Hand thought that these little red spots that we call petechial hemorrhages or glomulations, we thought that was IC. But now we know that when you stretch the bladder, that happens. So that was a false marker. But for many years, patients were told they have glomulations, therefore they have IC. If you look at our new IC guidelines, that's completely thrown out. The first IC research guidelines created by the National Institutes of Health in 1987 included both lesions and glomulations in their diagnostic protocol, but trouble soon emerged with this approach. One researcher performed hydrodistensions on women who had no bladder symptoms and discovered that they too had glomulations during the test. More worrying, the first NIDDK IC research project, the IC database, determined that 60% of patients struggling with symptoms did not have either lesions or glomulations on the bladder. With hindsight, we now realize that these patients probably had pelvic floor or nervous system dysfunctions, which triggered their symptoms. In 2011, the AUA released their first guidelines for the diagnosis of treatment of IC. They took no side in the Hunner's lesion or glomulation debate and focused on symptoms. They defined IC as, quote, an unpleasant sensation, pain, pressure, discomfort, perceived to be related to the urinary bladder and associated with lower urinary tract symptoms of more than 6 weeks in duration in the absence of infection or other unidentifiable causes. Today, the international IC research community agrees that glomulations have very little significance and are most likely a false positive caused by the test itself. Patients with glomulations who do not have urinary symptoms do not have IC-BPS. Most researchers now believe that Hunner's lesions are a separate disease. Biopsies from Hunner's lesions suggest an inflammatory disorder due to significant inflammation present on biopsy, as well as a deterioration of the urothelium. In contrast, patients without Hunner's lesions show no inflammatory disease, and their bladder often looks normal despite often severe bladder pain and symptoms. Today, an estimated 3 to 8 million women and 1 to 4 million men in the United States are affected by IC-BPS. It's not unusual for patients to visit several doctors before they receive a correct diagnosis or treatment. All right, so symptoms. The symptoms of BPS are urinary frequency, urgency, pressure, nocturia, which is urination at night, or pain. They can be mild, moderate, or severe. The challenge lays in distinguishing which structure is triggering these symptoms. Is it the bladder wall, the pelvic floor, the nerves, or other organs? Patients with bladder wall dysfunction usually experience worsening symptoms and discomfort as their bladder fills with urine that is then relieved with urination. Patients often describe bladder pain as ground glass, paper cuts, a lit match, or a twisting knife in the center of the pelvis just above the pubic bone. And these patients may struggle with extreme frequency and nocturia, with the more severe cases urinating up to 60 times a day. But tight pelvic floor muscles can also trigger urinary frequency, urgency, and pain. These patients often notice that their pain is worse, not before urination, but afterwards. Movement, exercise, intimacy, or traveling in a car can trigger pain. And rather than being sharp, pelvic floor pain is often achy, dull, and has a burning quality to it. These patients often struggle to start urination or may struggle to empty their bladder or bowels because their muscles are tight and dysfunctional. Intimacy and sexual relations are, of course, also affected. Physical nerve injuries are also possible. Pain from pudendal neuralgia can be electrical or searing in nature, especially when sitting. Patients often report a vibration, almost as if they were sitting on a cell phone on vibrate. Numbness, pins and needles, tingling on the skin are clear signs that nerves are involved. A painful arousal sensation known as persistent genital arousal disorder can also occur. Regardless of the cause, pelvic pain can be devastating to quality of life. One study found that the pain of IC to be more severe than the pain of advanced bladder cancer. Okay, diagnosis, how to find a physician. Let me get a drink here. Interstitial cystitis patients are usually treated by urologists or urogynecologists. Local physicians may not be thoroughly trained in the new models and subtypes for IC, nor do they have the budget to attend national conferences where they can review the latest research and take classes. They may not even be aware of the AUA guidelines that were released in 2011. Interstitial cystitis and pelvic pain is a rare subspecialty. As you do your research into a clinic or physician, review their websites and see if they have an interest in IC, OAB, or chronic pelvic pain. There are physicians who are caring, compassionate, informed, and dedicated to their IC patients, but they can be a bit harder to find. Don't be surprised if you need to travel to see a regional or national expert. And it is well worth your time to work with someone who's passionate about IC care. The Interstitial Cystitis Network and the IC Association have physician listings on our websites that will help you get started. Now, preparing for your first appointment. You and your physician work as a team. Your job is to be proactive and informative so that you can assist them in understanding your body and making a diagnosis. Be prepared to talk about your symptoms in detail. There is no shame nor blame in having bladder pain or discomfort. It's time to let it out. Your physician needs to know exactly how you are feeling and where it hurts. Be as specific as you can. Before your appointment, take a moment to ask yourself the following questions. Where is your pain? Is it in the center of your body? Is it to the left or right of center? Is it by your hip bone? Is it low in your abdomen behind your pubic bone, or is it higher up by your belly button? Does it extend to your back or your legs? Do you have any pain on your skin, such as on your vulva or near your rectum or scrotum? Does the pain get worse as your bladder fills with urine? Does the pain hurt the most after you're done urinating? Do you strain to empty your bladder? Do you have pain while you're urinating? And if so, where is that pain? What makes your symptoms worse? What makes your symptoms better? Do you have pain with intimacy? Do you have pain while sitting or walking? Does movement make your pain better or worse? If so, how? Do you feel a heaviness in your pelvis like you're holding a bowling ball? Do you feel a downward sensation like something is falling out of you? Do you feel an upward sensation like something is being pushed up inside of you or stuck inside of you? Do you notice a vibration or fluttering in your pelvis? Do you or have you ever had a painful arousal? Were you an athlete, a dancer, or in the military? Did you suffer any injuries to your pelvis? And do you or any family members also suffer from IC or other painful conditions? Make a list of any pelvic traumas or accidents that you might have had, such as a fall, surgery, or difficult childbirth. Make sure that you also include any other painful conditions that you have, such as IBS, migraines, fibro, endo, vulvodynia, prostatitis, prostate pain, testicular pain, and rectal pain. Now, your first appointment. At your first appointment, your doctor will review your medical history. They will ask about your symptoms. Share the information you develop from the questions above. They should perform a basic examination to look for other conditions which can also cause bladder and pelvic pain, such as tight pelvic floor muscles, endo, etc. And don't be afraid of this examination. It is essential that they examine your pelvis because so many structures are so close together. Yes, the urologist will probably do a brief vaginal exam or rectal exam because this is the only way that they can touch deeper structures and muscles within your pelvis. They will also perform several routine urine tests to rule out infection, including STDs. And for patients with a history of smoking or blood in their urine, a cytology test to rule out bladder cancer. The American Urology Association does not recommend additional invasive testing unless the diagnosis is in doubt. Rather, they encourage the use of more simple, benign methods. The PUF questionnaire is used in many clinics around the world to differentiate between bladder versus reproductive pain. A simple anesthetic challenge, the installation of a numbing agent into the bladder, can also quickly determine if the bladder wall is a source of pain or discomfort. Now, follow-up testing. For patients who have more complex symptoms or who have blood in their urine suggestive of Hunner's lesions, may need a cystoscopy or a hydrodistension with cystoscopy for a closer examination of their bladder. A cystoscopy is a minor procedure that can be performed in your doctor's office to briefly examine the bladder and rule out other conditions such as bladder stones. The urethra is usually numbed with a lidocaine gel. A small cystoscope is then inserted for a quick look around the organ and then withdrawn. Hold on, I need a drink. Okay, let me get my it is hard on the throat to talk this long. Give me a moment. Okay. Okay, let's get back to a cystoscopy. A cystoscopy is a minor procedure that can be performed in the doctor's office to briefly examine the bladder and rule out other conditions, such as bladder stones. The urethra is usually numbed with a lidocaine gel. A small cystoscope is then inserted for a quick look around the organ and then withdrawn. The urethra can be tender for about 24 hours after this test, particularly during urination. This usually resolves with time. Most patients are stunned that their bladders look normal during this exam, despite having severe symptoms. This suggests that structures outside of their bladder might be triggering their symptoms, such as muscles and nerves. And please note that there are special cystoscopy methods, such as narrowband imaging, that can be used to identify Hunner's lesions without the need for anesthesia, but these require special equipment and training to use and are not widely in use. Okay, hydrodistension with cystoscopy. For patients with more severe symptoms who are not responding to basic therapies or have significant blood in their urine, a cystoscopy with hydrodistension is recommended. This test allows the physician to closely examine the bladder wall. and should always be performed as an outpatient procedure under general anesthesia. During this test, the bladder is greatly expanded with fluid. The physician then inserts a cystoscope to examine the bladder wall. If lesions are found, they are usually treated at the time with laser therapy, electrocautery, or steroid injection. Doctors may also take a biopsy for further study. Once thought to be important, the presence of petechial hemorrhages on the bladder wall are no longer considered significant and are believed to be caused by the test itself. As a result, hydrodistension with cystoscopy is no longer the gold standard diagnostic test for IC in the United States. About 1/3 of IC BPS patients experience temporary relief from the test because sensory nerve fibers are damaged and the bladder is enlarged during the procedure. The nerve fibers do, however, grow back within a couple of months. Hydrodistension can have a longer recovery period with, for some, severe pain that requires pain meds. While optimistic physicians might suggest that you can return to work in a day or two, it may take a week or longer. The test is performed at a high pressure for a long duration of time. Bladder rupture is also possible. It is important to verify with your physician that they will follow the AUA recommendations of lower pressure, short duration to minimize trauma to your bladder. Postoperative bladder infections are also common. If your symptoms worsen during your recovery period, call your doctor immediately so that they can check for infection. Urodynamics. Urodynamics testing is not required for a diagnosis of IC, nor is it often done. A urodynamics test allows the doctor to determine if your bladder's nervous system is functioning normally. Performed during an office visit, the bladder is slowly filled with fluid. The doctor will ask you when you first feel a sensation of fullness, when you first feel the need to urinate, and when you first feel discomfort. Basically, the test measures your bladder capacity while awake as well as the electrical activity of your sphincters. An older and quite painful method for assessing the health of the bladder wall was to instill a strong potassium salt solution into the bladder. Studies have found that the KCl test is unreliable in establishing a diagnosis of IC. Most urologists now prefer to use an anesthetic challenge to test the integrity of the bladder wall. They simply instill lidocaine or marcaine solution into your bladder. If this numbs the bladder and reduces or eliminates your symptoms, it logically points to the bladder wall as the source of the pain. However, a knowledgeable urologist can usually tell if a patient has a leaky gag layer by asking which foods or drinks trigger symptoms, thus avoiding both tests. Patients with bladder wall damage consistently react to wine, coffee, tea, and soda. Now, confusable conditions. Lisa had been diagnosed with IC for over 10 years. She tried every bladder therapy available with no improvement in her symptoms. While pelvic floor physical therapy was somewhat helpful, she shared okay, I changed the name, but the patient I'm talking about here is in this meeting or was in this meeting just a few minutes ago. Okay, while pelvic floor physical therapy was somewhat helpful, she shared it was also always excruciating in one location. After attending one of the ICN's live support group meetings, she learned that the pain to the left or right of the bladder was unusual. She requested additional testing where they discovered she had a large mass of scar tissue interwoven through her pelvic floor muscles. You know who you are. She knew exactly when that occurred. She'd taken a very severe fall from a horse. Bladder therapies would have never helped her. She required surgery to remove the mass. John struggled with urinary frequency, urgency, pressure, and pain for 3 years before contacting the ICN. An Ironman athlete, his condition worsened despite the use of several bladder and prostate meds. He was, however, not diet sensitive. In fact, he could eat any food without triggering bladder symptoms. A visit to a pelvic floor physical therapist uncovered the root of his problem, severe pelvic floor muscle tension and pudendal neuralgia, likely the result of very long workouts on his bicycle. Heather spent years on various IC meds with no improvement. Her worst pain was near her urethra. Years later, a nurse practitioner suggested additional testing, which revealed a large urethral diverticulum, a pouch that extended from her urethra that collected urine. And after it was surgically removed, her symptoms resolved. Jane struggled with severe anxiety. She refused all testing, suffered with IC symptoms for years. When she finally allowed her urologist to look in her bladder via cystoscopy, they found a very large bladder stone. And once that was removed, her symptoms resolved. The American Urology Association advises patients and their medical care providers to take a step back and revisit their diagnosis if they're not responding to treatment or if their condition is worsening. There are dozens, if not hundreds, of conditions that can mimic the symptoms of IC and cause pelvic pain. And not surprisingly, some patients can point to a specific event which triggered their symptoms: falls, trauma, chemotherapy, surgery, travel, pregnancy, and abuse. Tailbone injuries, for example, are remarkably common in the IC patient population. If a tailbone is healed out of position, it will strain the pelvic floor muscles and could trigger bladder symptoms. In 2020, a fabulous book, Facing Pelvic Pain, was released by Massachusetts General Hospital, featuring experts in urology, gynecology, gastroenterology, neurology, orthopedics, rheumatology, and more. It is ideal for patients who are trying to unravel the mystery of their pain. We recommend it highly for anyone who is still struggling to find relief. So what are the conditions that can affect men and women and mimic IC? Well, number one, bladder cancer. If you're a smoker, you got to look at that. Radiation cystitis, if you've gone through radiation for chemotherapy, for cancer, that could trigger some bladder issues, and so can chemotherapy-induced cystitis. Tioprophenic-induced cystitis, that is a medication that's known for doing that, kind of like ketamine. Ketamine cystitis. Overactive bladder, bladder neck obstruction, urinary retention, neurogenic bladder, bladder stones, infection, pelvic floor dysfunction, pudendal neuralgia, Tarlov cysts, bladder wall perforation or traumatic injury, urethral diverticulum, and this is something that we only recently discovered, black mold. If you have black mold in your home, that can cause the symptoms we associate with IC. Conditions that affect women that can mimic IC are genitourinary syndrome of menopause, urogenital prolapse, endometriosis, fibroid tumors, pelvic congestion syndrome, and posterior fornix syndrome. And conditions that affect men that can mimic IC, chronic prostatitis, benign prostatic hyperplasia, and prostate cancer. There you go. That's chapter 2. The next chapter is on treatments. All right. My throat, my voice won't make it through another chapter. All right, my friends. Kayleen, are you still here? Kayleen, my dear, are you still here? Donna, are you still here, honey? We can go into Zoom. Kayleen, you wanted to go into Zoom. I don't know if you're still here or not. Or we can do it this week. All right, my friends. Well, I tell you what, let's call it here. I truly hope that you have a good week. Oh, wait, hold on. Tanya saves today with another question. I had a cystoscopy, and afterwards my pain skyrocketed. Since that time, I've not been able to eat any acidic food and have been in a flare cycle. My urologist told me the cystoscopy has never hurt anyone before, but I know something happened to me during this test. Could my bladder wall have been injured? Could my nerves and inflammation be causing the pain and sensitivities? Okay. So let's just clarify. Was it just a plain cystoscopy in the doctor's office, or was it a hydrodistension with cystoscopy done with under anesthesia in a local hospital? So what kind of cystoscopy was it, Tanya? The simple one in the doctor's office or the one in the hospital where you were under total anesthesia? Just a plain cystoscopy. Okay. So I have two theories. There are two theories about that. Theory number one is, obviously, when you put a cystoscope into the urethra and into the bladder, it stretches tissue. And that's why, and I'm sure you can attest to that, urinating after having anything put in your urethra, whether it's a catheter or a cystoscope, is not fun. It's and Tanya, I'm assuming they didn't put any fluid in your bladder. They just numbed your urethra, stuck the cystoscope in, looked around, pulled it out, you're done 3 minutes later. Or were they putting any fluid in your bladder when they did it? So if it's a looky-loo, that's just the in and out, take a quick pee. The urethra gets traumatized, so the urethra can hurt for a day or two. The first couple of times you pee are not fun. They could, of course, push the cystoscope in too far and scratch the bladder wall. This was 10 months ago. You had fluid placed in your bladder. Okay, so you had a hydrodistension, hun. You did not have I mean, they didn't do it. Did they do a treatment like a rescue installation, or did they, as part of the test, put fluid in your bladder? Was there an IV pole hanging next to you, and did they drain, and did they put a lot of fluid in your bladder? Or was it something they asked you to hold it for 20 minutes and pee it out? It always upsets me if a doctor does a hydrodistension in their office without anesthesia, because the worst thing you can do to the bladder is stretch it. So again, Tanya, did they just, was it a fluid that you held for 20 minutes and peed it out, which tells me it's an installation, or did they put fluid in your bladder as part of the test? Do you remember? Okay, so you had a urodynamics. So Tanya said no treatment. They wanted to see how much I could hold and see when I would feel like I needed to pee. You were testing for overactive bladder. Okay. So again, so with a urodynamics, what that's doing is that's testing your nerve functionality. So that's not a hydrodistension. A hydrodistension, they put a lot of fluid in your bladder and they under pressure, and they hold it in there, and it deliberately stretches the bladder. Urodynamics does not stretch the bladder to any great degree. What they're going to do is numb your urethra, stick the equipment in, and then they slowly fill your bladder with fluid. And then they say, all right, tell us when you first feel an urge to go. And you go, okay, I need to pee. And then they'll add some more, and they'll go, okay, tell us when you first feel pain. And you're like going, okay, it hurts, you can stop now. And then they might go a little bit past that threshold until you're going, get that effort out of my body, it hurts. At least that's how I reacted to a urodynamics. And all that's doing is just giving them information on what we call your awake bladder capacity is. So the question is now you've suffered a severe flare because of that. So can equipment damage your bladder wall? Yes. So concept number one is, how would we know your bladder's damaged? Well, were you bleeding? When you went home, were you peeing? I mean, was there blood in your urine? If there is blood in your urine, then yes, they definitely, something broke. If there was no blood in your urine, that kind of rules out the concept that you had an injury. And even if you had the injury, it should have healed by now. You know, healing always happens. The second thing that we have to really clearly understand is the pain of the test itself could have put your pelvic floor muscles into long-term tension. So you could you know, the way our body is wired is when you're in pain, your brain instructs you not to move that area. It's called the guarding reflex, and it's trying to protect you. And so when you have pelvic pain, your brain sends messages to all of your pelvic floor saying, don't move. Don't move. It's trying to protect you. It's guarding you. And that tension can, especially if it's long-term tension, can explain why Donna says, I will talk to you later. I'll be back at the end of the month. Girl, anytime. Anytime. Honey, I love you so much. You are my sister from another mother. I am with you. I am with you. I am with you. Especially during those hard moments, I want you to pretend that I'm standing right next to you and I got my arm around your shoulders. Okay? And remember, you're a tough bitch in the best possible way. You're going to get through this. You all are going to get through this. Big giant hug. Okay. So, Tanya, we would look for superficial injury to the bladder wall. We would look for pelvic floor tension. And then the other thing I think that's perfectly reasonable to check for is infection. Because anytime you put equipment in the bladder, there's always the potential of introducing bacteria. I mean, we have research that shows that bacterial biofilms literally move up catheters from the outside of the body into the inside of the body. And if they did it in their office, you know, it does make you ponder the concept of sterility and stuff like that. Is there any chance that, you know, nosocomial infections are common after hydrodistension? Is it possible that you're actually now struggling with a bacterial infection or a fungal infection? And I think it would be really important for you to get your urine tested. And I would maybe even consider doing a next generation DNA urine test, which will look for both bacteria and fungus, because we now know that fungal infections are often the cause of bladder wall flares. So for those patients who have really severe painful flares, especially if you're flaring from sugar, after eating carbs, things like that, then we have to suspect a fungal infection, candida infection in your urinary tract. It's possible. I had one for 2 years, and I will tell you that fungal infection hurt. That was the most pain of any of the pain I'd ever had was the fungal infection pain. Tanya says, I have lots of pelvic floor tension. You've seen a pelvic floor physio. You had cultures done, no infection. I do stretches regularly. I'm on the IC diet. Oh, wait. Oh, yes. Hold on. Now, girl, you have introduced the fly in the ointment that you had a hysterectomy and abscess just prior to that. Lots of full-scale antibiotics, complicated year for me. You know, my hysterectomy was very complicated too. Listen, girl, hysterectomy is brutal on the pelvic floor, brutal. And so, you know that, have you ever heard the term ischemia? ISCHEMIA, ischemia. Ischemia is reduced blood supply. Ischemia is bad. And areas that are affected by ischemia, they're just not healthy. They're not getting proper oxygen and nutrition, and eventually they could even die. I mean, the area that's affected by the ischemia could really struggle. So when you have super, super tight muscle, pelvic floor muscles, you have ischemia in your pelvis. And that's reducing blood flow everywhere. It's reducing blood flow to your vagina. It's reducing blood flow to your vulva, your rectum, and of course your bladder. And that's going to take a toll on your bladder. If your bladder is supposed to get 24 or 28 units of blood a day and it's only getting 10, Are you going to have a healthy bladder wall? You're absolutely not. But for the ischemia patient, listen, no bladder treatment's going to fix that. What's going to fix that is working with muscles. Tanya said, I've heard you talk about ischemia. You asked your urologist about it and they disregarded your comment. Well, that's a urologist for you. As Dr. Weiss, a urologist who wrote this book, writes in his introduction, Western medicine fails the typical pelvic pain patient because doctors stay in their sandbox. You know, urologists stay in the urinary tract, gastroenterologists stay in the gut, gynecologists stay in the reproductive tract. They don't look at influences. They don't look at influences. And that's the entire point. That's why so many patients don't respond to bladder therapy, because the underlying problem is not the bladder. The underlying problem is pelvic floor. Let's see here. Let me see if I can. I wonder. The pelvis is a vast living network of interconnected structures. Pelvic pain and dysfunction do not exist alone because changes in body mechanics, physiology, and chemistry. Because biochemical interactions are not a one-way street, any abnormalities outside the pelvis can also affect the pelvis. Examples include pelvic floor and nerve problems that also arise from a dysfunction of feet, spine, jaw, bladder, uterus, intestines. Furthermore, chronic pain can sensitize the entire nervous system, thus producing a total body impact. So I'm not surprised. What I would do is I would go to your gynecologist. I would go to the gynecologist and have your gynecologist check your pelvic floor. If your pelvic floor muscles are tight, well, you already said you have lots of pelvic floor dysfunction. So if it walks like a duck and talks like a duck, it's a duck. You have very, very bad muscles. And the trauma, I had a ton of trauma from my surgery too. And then you had the abscess and all that sort of stuff. I would be investing my time and money on working on those muscles. I would. You know, especially if your bladder wall's healthy. I mean, my bladder wall's healthy. It's always been healthy. PK here on YouTube says, I have tight pelvic floor. Yeah, I mean, 85% of IC patients have tight pelvic floor muscles. It is what it is. That's why we call this a neuromuscular disorder. So who cares what they think? The point is you have tight muscles, so let's do something about it, right? And you just have to remember that, listen, a lot of the stuff that I'm talking about is only talked about by the top IC researchers and clinicians. You're literally getting a master class in what the leaders around the world are thinking about IC. That information has not trickled down to the local urologist. It's not. And that's our big obstacle, is how do we get that information to them? Because they don't go to the conferences and take the classes. And when they do go to a conference, they're going to the cancer class. They're not going to the chronic muscle tension class. That's why physical therapists are really, and physiatrists are really our go-to. Tanya says, if I can get my muscles to calm down, do you think I would eventually eat acidic food? You know what? Okay, Tanya, I can. So I have been on a quest to lose weight because a cinnamon roll had never tasted better than during a pandemic, and I gained at least 15 pounds over the pandemic. I've lost 12 of those 15 now. And my dessert, you know what my dessert has been for the last couple of weeks? A tangerine. A tangerine. Sometimes 2 of the little tiny tangerines. That's my dessert. No more ice cream. Every now and then I have a cookie. And so I can eat all those acidic foods now. I couldn't when this all started. I was very diet sensitive. I can now because my muscles are much healthier. My circulation is much better. And I'm no longer an ischemia patient unless I let things get super, super tight again. PK says, I'm scared to go, but want to know if I have Hunner's lesions. I called for my x-rays from 20 years ago. X-rays are not going to show Hunner's lesions. And, I mean, PK, listen, why waste time guessing? We make sometimes catastrophic mistakes by letting fear stop us from going to the doctor. And I did that before when I started bleeding and had the early uterine cancer. I waited 9 months. I let fear stop me. You can't let fear stop you. If you think you have Hunner's lesions, then there's no reason why you can't go to the doctor and, number one, ask if they have narrowband imaging. A narrowband imaging would allow them to find Hunner's lesions with a simple cysto. You'll know in 5 minutes. And if they don't do narrowband imaging, and if you've got persistent blood in your urine and your symptoms are really, really severe and you're very diet sensitive, what do you got to lose? Give them a chance to look in your bladder and see if there's anything funky going on there. If you don't let them do that, you're forcing them to guess, and you deserve more than a guess at this point in time. You suffered. I mean, the thing that they did to find out what I was diagnosed with, IC. Well, it was a long time ago, and a lot has changed. So today, a diagnostic workup means we got to check your urine, got to check your muscles, got to check to see if you have blood in your urine to really try to understand what could be driving that. And are you food sensitive? If you're food sensitive, then that tells that master IC clinician that your bladder wall is compromised. And generally they give you the diet, they give you a couple of things, and because for a lot of women, it's just diet. Once we get off of the diet, the bladder pain improves dramatically. That's easy, and that usually doesn't require a cystoscopy or a hydro. But if there's any doubt, or if you're in pain, or like for me, I just thought I had cancer. I spent a year thinking I was dying of cancer back then. I was obsessed with it. And every day I worried that I had cancer because I couldn't imagine anything other than cancer causing the pain that I was in. And I asked my OBGYN, I said, all right, I want you to look. I want exploratory surgery. He's like, really? And I'm like, oh yeah, I need you to look. Please tell me what the hell is wrong that's giving me all this pain. He's like, okay. And I had it done in September of 1993, 3 weeks after I got 7 weeks after I got fired by my employer at that time. And I was shocked when we woke up in the recovery room and he goes, Jill, your bladder's fine. Or no. How did he say it? No. What he said is, you don't have cancer, you don't have endometriosis, it's just your bladder. No, that's what he said. That was in 1993. And then when I had my hysterectomy and they did a hydrodistension, he goes, Jill, you have a healthy bladder. Your bladder's perfectly normal. This proves it was never your bladder. It's always been your nerves and muscles. And that's a good example of what we learned in those 30 years. Because back in the 1990s, we're going bladder disease. But, 7 years ago when I had my hysterectomy, they were like, okay, no, we're looking at nerves and muscles now. And to have those pretty pictures of a completely normal bladder was exciting. It's like, okay, I get it now. Now I know why bladder treatments didn't work for me. End of story. It's just really, so we're really making... Renee says, thank God, I'm a hyper nerve pain person. Yeah. Yep. I think just finding some peace in this body, finding some peace and context and why this happened, and not blaming ourselves and not worrying. I mean, sometimes the most important thing that patients need to hear from me when they call me and we have a nice long chat is, honey, I'm not scared for you at all. You're not peeing blood clots. There's no sign that you have any severe, scary disease. What you sound like is an estrogen atrophy patient. based upon your age, combined with the fact that you have tight pelvic floor muscles. That's good news. Let's work on that. On the other hand, if you have extremely severe pain and you're peeing blood, man, that's an emergency. We got to figure that out. What the hell is that? Tanya says, thank you for all of your wisdom and help these past months. You've been so helpful, even when things felt helpless. Tanya, that's the nicest thing you could say to me. Thank you. You just made my day. All right. Well, my mouth is hurting from talking so much. I got to let all these nerves calm down from the surgery I had. So I think I'm going to call it here. You hope you guys have a fantastic, fantastic, fantastic week. And if you're facing a difficult week, you know we're here for you. And we stand behind you and beside you. All right? All right, my friends. I'll see you later, alligator. All right, YouTube. See you later.